Good afternoon, everybody. Today we are starting the session. Today the speaker is Dr. Biswajit Naik, Associate Professor, IMSM Some Hospital, Bhubaneswar. He is presenting, sir will be presenting on acute exacerbation of COPD. Sir, after you, sir. Please start. Biswajit, sir.
Only it's showing.
Yes, sir, it's showing. You can proceed, sir.
So, first topic is COPD. So, the new guideline of World 2023 has defined that COPD is a heterogeneous lung condition characterized by chronic respiratory symptoms like dyspnea, cough, sputum production due to abnormalities of the airways like bronchitis and bronchiolitis and or alveoli that cause persistent and often progressive. That is the most two common one is a persistent and it's progressive airflow obstruction. So, but the acute exacerbation of COPD is defined as an event characterized by dyspnea and or cough, but it is worsening within the less than 14 days and is often associated with increased local and systemic inflammation caused by the airway infection, usually also by the pollution or other insult. So the problem is in the 1990 it was the sixth leading cause of death, but now it's the third most common cause worldwide and accounting for the nearly 3 million deaths in the 2019. So it's a huge economic burden and the hospital mortality rate is 10%. And the rate is the death incidence also increased because due to increased use of the smoke and also there is pollution and increased expectancy of the patient. Coming to diagnosis, diagnosis is the mostly clinical. It's dyspnea, which is progressive, and most commonly with worsen with exercise, and it's persistent dyspnea, and it's chronic cough, maybe intermittent or maybe unproductive, and there is history of exposure to risk factor like tobacco smoke, most commonly by that local with the local preparations and smoke from the home cooking and other biofuels. So, and there may be family history of COPD. What it is forwarding.
Sir, the slides are not moving.
Ah,
It's still in the diagnosis of COPD
just
slide.
Double click.
yeah. I also it moves. Just a minute.
Double click, na it will move.
So, so by spirometry, the post-propylate dilator FE1 by FBC is less than 0.7. Coming to differential, there may be different conditions simulating like plasma, but asthma most commonly in children, and there is episodes most common in the night, and in the congestive heart failure, we can find, but in congestive heart failure, we can find a patient is think for the sputum or patient with edematous, and we can get the pulmonary edema feature in the chest X-ray and large size heart. And in bronchiectasis, there is more cough production, and in tuberculosis, it's usually and fever, mild fever, and we get a patch in the upper lobe in chest X-ray. And fourth one is for obliterative bronchiolitis. It is most commonly after the bone marrow transplantation or lung transplant, and we get that hypotenuse area in the CT scan. So, it's showing now.
Yeah, make it full screen.
Sir, make it full screen.
So classification.
No, start from
Sir.
clinical features.
Dekauji.
Start from clinical findings.
Clinical findings. Okay.
Ah.
So there is change in mental status, intercostal retraction, paradoxical thoracoabdominal movements, use of respiratory auxiliary muscles, hemodynamic instability, or maybe right heart failure. In worst case, there may be hypoxemia and hypercapnia. Now coming to gold classification of COPD. Gold one, all COPD patient having FEV1 FDC ratio is 0.7, less than 0.7. But if it is mild, gold one like mild, it is FEV1 is more than 80% in after the post bronchodilation. In gold two, it's moderate severity where everyone is within 50 to 80. In severe cases, gold 3, it is 50 to 30. And in severe cases in gold 4, it is less than 30%. Coming to pathophysiology, does that cigarette smoke leading to activation of the epithelial cells, leading to increased TGF beta, which activate fibroblasts to increase the fibrosis from the smooth muscle cell. And smoke activates macrophage through CXL and CXCL8 receptor. It activates the neutrophil, which increases the protease enzyme. So there is uh, uh, alveolar wall destruction, and also there is production of mucous gland and more edematous. So three things is important: the narrowing the airway, inflammatory mucosal edema, and increased fluid and cell exudation. And there is progressive irreversible airway obstruction. And the peripheral airways is usually decreased to less than 2 millimeter in diameter. From that, again from tobacco, that smoke, that nicotine compound leading to transmigration of the neutrophil from capillary, which increases, from the from that smoke, there is free radicals, which leads to inactivation of the antiproteases. Like that, there is a state of functional antitrypsin deficiency, and also there may be congenital antitrypsin deficiency, which is leading to increase the elastase enzyme, leading to tissue damage. So all about it's the imbalance between the proteinase and antiproteinase enzymes. So there is loss of in the X-ray you can find loss of surrounding lung parenchyma. There is only some parenchyma. There is air trapping and decrease the elastic lung elastic recoil forces. So in normal, the elastic force is the normal, but in COPD, the elastic force is decreased, so it is tightened. So during the exhalation, so that elastic force is reduced, so it will collapse. The airway will collapse each other. So there is less negative pleural pressure and diminished transpulmonary pressure. So now coming to what happened in the respiratory mechanics. So in the normal, like in the one complaints in the one, this graph, there is in the change in the same change in the volume, there is change less change in pressure. But after that, in the complaints 2, we can find the same change in the volume. There is a increase in the pressure. The insert pressure in the alveoli is too much. So leading to increased worker breathing, hyperinflation, increase the dead space, and there is generation of the autopsy. So there is after some time there is decreased muscle efficiency due to altered geometry of the chest wall and diaphragm, hypoxemia and respiratory acidosis leading to impaired energy metabolism of the muscle, and respiratory cachexia also is there. So this factor leading to decreased muscle efficiency. So in COPD, airway obstruction leading to hyperinflation, increasing work breathing, and further leading to respiratory muscle fatigue. So hyperinflation leads to increasing autopeep and decrease the compliance, which further increase the work breathing. Also, there is ventilation perfusion mismatch in COPD, leading to hypoxia and hypercapnia, which further impair the hemodynamics. The all leading to respiratory muscle fatigue, and patient goes into the vicious cycle, leading to respiratory failure. Now coming to management. So criteria for ICU admission is inadequate response to initial therapy, persistent and worsening hypoxemia, persistent and worsening respiratory acidosis, PS less than 7.25, and need of invasive mechanical ventilation and hemodynamic instability. So a night at the ICU is better than a life in the grave. These are same indication from the gold criteria. So aim of the ventilator support is to rest the respiratory muscles. So how we can raise the muscle by treating the underlying acute exacerbation and reverse the bronchial obstruction by giving beta 2 agonist and reduce the inflammation by giving the steroids. So initial management is obviously NIV. So that may be indication like respiratory acidosis of PCO2 more than 45 with arterial pH of less than 7.35. There is symptomatic like severe dyspnea with clinical signs of respiratory muscle fatigue and persistent hypoxemia requiring oxygen therapy. And study shows NIV improved the mortality, shorter hospital stay, decreased need of intubation. So when NIV patient must be sedated and reassured, start with pressure support mode. The pressure support must be 6 to 8, then PEEP is 3 to 5, F5 to get the saturation of 88%, and try to PEEP and pressure support step by 1 to 2 centimeter quarter. So usually goal is to get the patient's comfort, and respiratory rate must be less than 25, and dial volume must be 6 to 8 ml per kg. So when I know the NI failure, like absence of improvement, pH less than 7.25, RR more than 35, and this low GCS. So better don't delay intubation patient if patient is worsening. So if NIV is failed, then we should go for the invasive. Hello.
Sir, your
Hello.
PPT got disconnected. Sir,
Okay.
I think there is connectivity issues. I think you have to share your PPT again.
Okay. Now showing.
Yes, sir. Yes, sir. It is visible.
So invasive ventilation used mainly by the large diameter tracheal tube. Neuromuscular paralysis should be cautious because already there is respiratory muscle weakness. Alternative use like hesitation and continuous display of the ventilator waveform. The indication, it's a NI failure in case of cardiac arrest, respiratory arrest, diminished consciousness, massive aspiration, persistent secretions, hemodynamic instability, and arrhythmias. Now the problem with invasive ventilation is dynamic hyperinflation. What is this? The first patient is uh, normal inspiration, but there is obstruction in the airway, so there is expression is not coming to baseline. So again, in the next breath, again there is normal inspiration, but expression not coming to baseline. So like that, like in every cycle, the there is some air is trapped inside the lungs, so leading to dynamic hyperinflation. We know from that waveform, like this is a normal dotted one, so coming patient after exhalation, it is coming to baseline, but in the COPD patient, the expression not coming to baseline. Here it is there. So some amount there is this much of air trapping is needed, which leading to generation of autopy. So our aim is to normal the pH, not the PCO2. So our goal of fermentation is fermentation is less than 115 ml per kg. That volume is 800 per kg. Respiratory rate must be 10 to 14, and inspiratory flow is 80 to 100 liter per minute. And practication must be less than 30. The end inspiratory trial volume is the volume above FRC. So here is the inspiration, here is the normal trial volume expression. The further till the FRC, and from the inspiration point, it is called the end inspiratory volume. And if it is more than 20 ml per kg, it is predictive of complication. Now, how to measure uh, PEEP, auto PEEP? This is the normal graph. We can know by giving a expiratory hold and the ventilator bottom, and then we get the total PEEP here. So here we get the external PEEP by IOS, and here is the, so it's the total. So this part is the intrinsic PEEP. So how will we reduce the auto PEEP? Providing the long expiratory phase, patient ventilatory demand must be reduced, and decreasing the minute ventilation, and we should reduce the airflow resistance by bronchodilators and steroids. So is adding external PPs further worsening or it is helpful? So we can understand by this the alveolar pressure, that is total auto PEEP generated. Here is the what we get the external PEEP. So like flow of water or air is not affected till until the downstream, that is the external PEEP is above the that is critical pressure. Then there may be no flow, but till it is alveolar pressure is high and external pressure is low, then there is easy exhalation. So there is no problem in adding external PEEP. We can understand with this picture also. Here there, when there is no PEEP is applied, so there is zero, and there is uh, while in the expiration phase there is plus 8, so there is the air exhales. When patients try to inspiration, there is no flow. This can becomes zero, so it becomes that real pressure needs -8. But when the inspiration begins, flow begins, there must be this must be -1. So this alveolar pressure must be -9, so that it will generate -1. So from +8 of real pressure to now its requirement of -9. So huge large amount of negative pressure is required for the flow to begin in the COPD case. But what happens if we give the some PEEP, like some extrinsic PEEP, we give like give the PEEP of 6, then see now it's +8. In the previous case it's +8, but now when the start of inspiration it is 6 to have normal equal set like 6, so it is will be 6. So only by -2 it's the inspiration starts, and to flow to begins it must be less, so only by making it 5 the flow begins. So it needs from +8 to -3, so there's less chance of pleural pressure. So we get is by giving the PEEP, we can easily reduce the negative pressure needed to generate the flow. So external PEEP is helpful. So how much you give the external PEEP? So external PEEP is 80% of the inspiratory PEEP to release substantial relieve the inspirator workload and no risk of increasing hyperinflation. Coming to what is the interaction? Cardiopulmonary interaction like positive increase in the positive intrathoracic pressure due to hyperinflation leading to decreased venous return and preload, increasing pulmonary vascular resistance and afterload of the RV, which reduces the cardiac output. And after acute RVA failure leading to leading to septal shifting to the left side, leading to left ventricle filling difficulty due to ventricular interdependence. This is the case is usually seen in the dynamic hyperinflation. So in this case, we can disconnect the ventilator. Now coming to non-ventilator support, inhaled beta 2, both in the asthma and COPD role has a role. Inhaled anticholinergic, mostly work in the COPD. Systemic, some role in the systemic steroids also. Antibiotics have definite role in COPD as usually the infective is the exacerbation cause exacerbation, and oxygen should be given cautiously, and NI has a definitive role. Bronchodilator, coming to bronchodilator beta 2 agonist, anticholinergic you can use, combat therapy is usually used, and nebulizer given through compressed air. Inhaled corticosteroid improves system symptoms, lung function, quality of life, reduce the frequency of exacerbation, but increase the risk of pneumonia. Systemic steroid rapidly increase the FEV1, significant shorter hospital stay. You can use 30 to 40 mg of prednisone, but not more than 7 to 10 days. Anti-infective therapy, as there is 25 to 50 they have lower airway colonization, so it's the most common precipitating factor. Most common organism is Haemophilus influenzae, Streptococcus pneumoniae. In the hospital patient, if patient is moderate and severe exacerbation, at least 2 to 3 cardinal symptom, and complicated COPD like age more than 65, FEV1 less than 50, in more severe cases, COPD, and more than 3 exacerbation per year, and having cardiac disease, then there is risk factor for pseudomonas. If there is a risk factor, then we go for the ceftiofenib ceftazidime, and if there is no risk factor for pseudomonas, then we can go for ceftriaxone and cefotaxime. We can have the response in the look for the response in the 72 hours, and then re-evaluate for sending the culture or gram stain. So that is actually there is no role of the methylxanthine, but methylxanthine improves in FEV1, improving the coronary blood flow, reduce the neutrophil infiltration. But the problem is the ventricular arrhythmia and seizures. So monitor plasma levels is needed. But the study shows beneficial long is inconsistent, adverse effects is more, so should not be used. Supporting therapy is like correct of fluid imbalances, that is, as there is decreased pulmonary lymphatic drainage and increased chance of lung edema and right heart failure. So judicious fluid should be given. Respiratory exercise leads to further increase cerebral blood flow, decrease SBR, increase epinephrine in the normal use. So optimize mechanical ventilation so that there is decrease in respiratory stress. Alkalosis. Maurice, audible?
Yes, sir. Audible.
Okay.
For sure, sir.
Coming to alkalosis, we must avoid the alkalosis because hyperventilation may lead to alkalosis in the this patient. So symptomatic if P is more than 7.5, seizure, coma, or atemia may happen. Nutrition support imbalance, nutrition, so malnutrition in 30 to 60% cases, so early nutrition therapy is needed, but avoid overfeeding, but no benefit of pulmonary failure. So these are the some treatment without documented benefit like nicoactive agents, methylxanthine, nebulized magnesium, and chest filtrate. Winning the patient challenging. The clinical judgment is on the sensitivity is 35%, the specificity is 79%. Winning protocols must be there. These are the factors patient failed to win actually. Gas exchange, ventilation person mismatch, and ventilated muscle fat like patient is acute muscle fatigue, atrophy, ventilated factor like high resistance, the tracheal tube, small tube, tracheal tube, and metabolic factor like overfeeding, malnutrition patient. So these are the cardiovascular. There is left heart failure or PH, and neurological factor like critical illness, neuropathy, myopathy. So there may be winning failure. So early NIV prevents post-extubation respiratory failure and decreases reintubation rate and ICU mortality. So role of tracheostomy here, the right timing is needed and the impact on the duration of the mechanical ventilation. Long-term outcome, the poor outcome indicates that the patient is dyspnea at rest, pulmonary hypertension is there or pulmonary, irreversible airway obstruction despite the beta agonist, and pulmonary cachexia, several acute adjustments in the history, and patient having cardiomyopathy and nephropathy. These are the poor prognosis. Thank you.
Thank you for the lecture, sir. Without delaying much time, I want to welcome Dr. Shakti Mishra, sir, HOD, Department of Critical Medicine, IMSM Some Hospital, to talk on physiology and management of ARDs. Shakti, sir, please share your screen, sir.
The screen is visible.
Visible. Yes, sir, it's visible. Please proceed, sir.
Yeah. Good afternoon, everyone. Today's topic is ARDS. This is a very vast topic. I will be just telling the brief about most important points. So most of the what I will be saying is the must know area that you should definitely know before your practical and theory exams. So ARDS, it was first described in 1967 in this paper in Lancet by Ashbrook. He described 12 patients who had this acute respiratory distress, and they termed the disease or the syndrome as ARDS. Now, there were no formal definitions until the 90s. So before that, I will describe the risk factors that are resulting in the development of ARDS. So they are basically divided into two. That is the pulmonary, that is direct lung injury, or the indirect lung injury, that is extrapulmonary causes. The most common is the direct lung injury. And among the direct lung injury, the most common is pneumonia. It can be viral, bacterial, or fungal. And apart from that, aspiration of the gastric content, ventilator-induced lung injury, and contusion are other direct causes of ARDS. Coming to more common causes of extrapulmonary ARDS, it is non-pulmonary sepsis like abdominal sepsis, UTI, bloodstream infections, trauma, fat embolism, acute pancreatitis. Apart from that, neurogenic ischemic reperfusion after transplant, drug toxicity, TRALI, these are all other aspects. And there are some newer concepts like e-cigarettes and vaping, which are resulting in ARDS. So before we go to the diagnosis, a little bit on the pathophysiology of how this disease process develops. It is essentially divided into three phases. The first is exudative, the second is proliferative, and lastly fibrotic. So here you can see on the left side, the normal lungs. It has got a normal bronchial epithelium, the basement membrane, and alveolar epithelial layer, and the endothelium or the blood vessel. So this is the normal structure, and we will see how it gets affected in ARDS. So in the normal structure, here is a more magnified view. You can see that the airspace is dry. There is no fluid in the airspace. The junctions, that is the epithelial junctions, they have the tight junctions are intact. The same is said about the glycocalyx. The epithelial glycocalyx is also intact, and the normal surfactants are present, and the other normal channels are also present. The most important being the sodium potassium channel. So if you look at the endothelial side, in the endothelial side also, the intact endothelial tight junctions are present. The glycocalyx is intact. No adhesion molecules are seen. The normal WBC and RBC and platelet are. Sorry, I think I got disconnected. Which was the last slide?
The before slides.
The normal?
Before this.
Oh, before this, okay.
Yes.
So this is a schematic diagram describing the evolution of ARDS. It is basically divided into three phases: the exudative phase, the proliferative phase, and finally the fibrotic phase. So if you can look on the left side, you can see the normal structure of the alveolus, the epithelial layers, and the endothelium. We'll see a more magnified view. In this, the two parts that are divided are the epithelial part and the endothelial part. The epithelium, you can see the tight junctions are intact between the epithelium. The airspace is absolutely dry. The glycocalyx are intact. The normal surfactant are present, and the electrolytes transport channels are functional. The most important being the sodium potassium ATPase 1. Now, if you look at the endothelial side, the same thing can be said about the endothelial tight junctions. They are intact. The glycocalyx is intact. No adhesion molecules are present, and the WBCs and RBCs and the platelets are roaming about freely in the structure. So what happens in mild injury is there is, as you can see now, there is some fluid coming into the alveolar place. So this is mild edema is present. The tight junctions are now disrupted. The glycocalyx are being shed now. They are slightly distorted. The channels are blocked, and they are now secreting some cytokines as well. If you look at the endothelial side, the same is seen. The tight junctions are now broken. You can see the fluid between the two cell layers. You can see that the endothelial glycocalyx is also broken, and some RBCs are also now injured. And you can find the cytokines and their adhesion molecules. Now, what happens in the severe case is there is the edema increases both inside the alveolus as well as in the interstitial region. Now, the glycocalyx are totally fragmented in the epithelial slide with the presence of hyaline membrane. And here you can see that some of the RBCs and WBCs are migrating from the endothelial side to the alveolar side as well. Now, the channels are completely lost and the glycocalyx are completely shed. And the other thing that you can also see here is the presence of microthrombus. So again, summarizing the same thing, you can see the glycocalyx is completely shed. You can see the endovascular thrombus presentation, the flooding of the alveolus and the interstitial region, the breakdown of the basement membrane, and the inflammatory cells. So this is the initial phase, which is because of the injury, as we have discussed before. So what happens because of this? So because of the alveolo-capillary barrier injury and the edema formation, there is a decrease in the lung compliance, which increases the work of breathing. There is diffuse alveolar filling, which again results in the shunt, VP mismatch, and hypoxemia. The surfactant inactivation results in the end expiratory alveolar collapse, and which results in the requirement of positive end expiratory pressure when we are ventilating. The platelet and endothelial activation can block the microvascular thrombus, which was mostly seen in the COVID-19, resulting in increased dead space ventilation and pulmonary artery hypertension. So requiring high minute ventilation and hypercarbia with right heart failure. And the inflammatory markers can result in multi-organ dysfunction. Now, as you can see, there are two basically layers, the alveolar and the endothelial. On the left upper aspect, you can see the normal endothelial and the epithelial layer. While in the left lower part, what we see here is the alveolar inflammation. That is the inflammation of the epithelial layer. If the inflammation of the epithelial layer is present, we will find these biomarkers, the SRAGE, CC16, interleukin 1 beta, 6, 18, and TNF alpha. These are important because later on we will see what is the importance of these biomarkers or these particular cytokines in identifying the subphenotypes and targeting our therapy to those parts. So if we look at the right upper part, there is only vascular inflammation. Here you will see a rise in the decrease in protein C, increase in the PAI1, ANG2, and the cytokines. And there can also be combined inflammation. This is an extreme form where all the biomarkers are elevated. Now, again, the last two phases, that is the proliferative phase and the fibrotic phase. Proliferative phase is essentially the healing phase where everything that was distorted before, as you had seen, is coming back to normal. You can see that the channels are back. Your edema fluid is coming down. The interstitial fluid is coming down. You have the new channels coming in, which will help in reducing the edema fluid. The basement membrane is now re-established. And you can see the fibroblasts, which are here to remake the matrix. And the healing is being seen in all the phases. The inflammatory markers are coming down, and you can see the lipoxin and resolvins, which will help in reducing the inflammation and reversing the process. However, it doesn't happen in all the cases. Some patients do go into what is called the fibrotic phase. This is an extremely bad phase, and in this, the patient is becoming worse and worse. And here you can see the epithelial and the endothelial layers are absolutely damaged, and there is persistent intraalveolar flooding with inflammatory markers. And you can see here the proliferation of the fibroblasts, which will ultimately result in a fibrosis and permanent scarring of these areas, which will make the recovery of the patient more difficult as we go further. So how do we diagnose ARDS? As I said, after that 1967 initial report, it was in 1994 that the first criteria for ARDS diagnosis was done. So I will be telling all the criteria simultaneously. In the 1994 criteria, the timing was not specified, which was specified in the Berlin definition, where they made it a new or worsening respiratory problem within 7 days of the insult. In 1994, it was bilateral infiltrate in the chest X-ray, which was changed to either chest X-ray or CT scan, and which has been slightly revised in the 2022 revisions. But the 22 revisions are not actually accepted worldwide, but there are some suggestions to add ultrasound to the diagnosis to help in finding the bilateral infiltrates. Next is oxygenation and PEEP. In the 1994 definition, there was no PEEP specified. In the 2012 Berlin, they showed at least a PEEP of 5 should be given by CPAP. And if after that you get PF ratios of less than 300, it will be ARDS. In the initial 1994 definition, less than 300 was ALI, above 200. However, in the Berlin definition, it was classified into mild, moderate, and severe. Well, there have been some talks of trying to replicate or replace this with saturation divided by FiO2, the Kigali index. And next and the last one is to find what could be the cause of this alveolar edema. It could the previously the definition was a pulmonary artery wedge pressure of less than 17. However, in the Berlin definition, because of the decreased usage of PA catheters, statement was given that edema origin, which is not fully explained by cardiac failure, is to be given as a criteria. However, it's not a very specific thing. It means by history, clinical examination, and echo findings, you make a clinical judgment that the edema is not completely defined by cardiac failure. There is no objective criteria over here. And none of the criteria still now have looked into the biomarker part. But in the future, we need to work on that. I'll come to this later on. So coming to the treatment, the underlying cause is the most important thing, and this needs to be addressed and treated. The primary step is to identify, address the root cause, and in sepsis associated ARDS, early resuscitation, antibiotics, and source control are priority. This is the common thing that we'll get in our ICUs. So coming to the ventilation, so I will be just summarizing the most important trials. Each trial is very important and you need to know every detail about it. I won't be going into the every detail. I'll just tell the brief and the important findings. The most important one is the ARTSNet trial on the tidal volume, the ARMA trial. In this, they divided the patient into 2 groups, 6 ml and 12, and they found significant mortality benefit in the patients who were ventilated with 6 ml per kg. So this is the study based on which we use a 6 ml per kg ideal body weight for setting our tidal volumes. The next is the usage of neuromuscular blockers. The first study which showed positive outcome with the neuromuscular blocking agent is the Accuracy trial. This was done in 340 patients and it showed a positive outcome with lower trend of mortality in cis-atracurium group. However, the findings could not be replicated in the ROSE trial. However, there are a lot of limitations of the ROSE trial for all the practical purposes. Considering the physiological aspect and the previous positive trial with Accuracy, neuromuscular blockade do have a role. I will just show a little brief regarding this. What happens without paralysis is when the patient is breathing spontaneously, there is a difference between the patient's inspiration and the ventilators delivering the breath. So there is always a dyssynchrony between the two. So this difference between the patient effort and the ventilator's breath giving can result in 2 scenarios. Either sometimes it can give a large tidal volume and at times it can give a less tidal volume. With the large tidal volume, you have the problem of barotrauma and volutrauma. And when the tidal volume will be less, there is a chance of atelic trauma. So overall, all these trauma will result in biotrauma and the VLE and decrease oxygenation and more organ failure. This can be reduced with the usage of neuromuscular blocking agents, where you completely eliminate the patient's signals. So it's entirely ventilator-dependent breaths. So this results in the variations in the tidal volumes that we were seeing previously. So it results in a singular low tidal volume, which is provided in every breath. So this type of rest given early is postulated to reduce the biotrauma and improve the oxygenation. The next study where we find positive result is the prone positioning, that is the PROSEVA trial, where we found a significant reduction, that is 16% reduction in the mortality in the patients who were given prone position. So prone position should be given to all patients with a PF ratio of less than 150. Coming to ECMO, the previous trial, that the Caesar trial was a positive trial where they found good benefit with using ECMO. However, this study was replicated in a multicentric trial in this EOLC trial. However, they could not find significant reduction in the mortality with the use of ECMO. However, a later Bayesian analysis found there is some reduction in the mortality if you are using ECMO. But as we all have seen and experienced, ECMO has been used extensively in the COVID-19 pandemic, and it did save a lot of lives. So as of now, ECMO is a therapy which should be offered to patients who are in severe ARDS and are not showing improvement despite prone position. Regarding the oxygenation target, there have been multiple studies. I won't go into the details of this, but it has essentially been found that a conservative approach is not inferior. So giving a liberal oxygen is not necessarily required in these patients. Now, apart from that, there are studies on PEEP. Here, different levels for PEEP were tried in ARDS patients. And in this, they looked at the patient outcomes. Total 549 patients were identified and assigned to lower and higher PEEP groups with a set combination. And the average PEEP in the low PEEP group was 8 plus minus 3, and the higher PEEP group was 13 plus minus 3. And the death rates were similar in the two groups. However, the unassisted breaths again were slightly higher in the lower group, but essentially similar with no statistical difference. Now, with the similar clinical findings in both the groups, the PEEP levels were not clearly identified. And no PEEP was shown to be of clear benefit, neither the lower PEEP nor the higher PEEP. Apart from that, there is one major trial. This is the most important one, that is the driving pressure trial. Here they calculate the driving pressure based on this formula, that is tidal volume divided by the compliance, and they calculated the delta P, or the driving pressure. In this, they looked at the data of the previous ARDS trials, that is the previous 9 trials, that is 3,562 patients, and they found that delta P is significantly associated with survival, and an increase of delta P of more than 7 heightened mortality. Now, modification in the PEEP and tidal volume, when targeted to this delta P, helps in reducing BILI and improving outcomes. So this is the most important determinant of survival. Now, why we are looking at all these things is because of this concept of BILI, that is the ventilator-induced lung injury. So it can be because of the low lung volumes, which can result in acute lung trauma, atelic trauma, that is inhomogeneity at low tidal volumes, or if you are giving very high tidal volumes or high pressures, it can result in over distension or volute or barotrauma. So both these trauma will result in similar kind of picture as we had seen before, with the shedding of the epithelium and the glycocalyx and increase in the pulmonary edema, finally resulting in inflammatory activation, resulting in multi-organ failure and death. Now, apart from the ventilatory strategy, there are other set of supportive strategies which are used. That is the use of conservative fluid management. Now, many of these ARDS patients, because of their sepsis, also develop hypotension and shock, resulting in fluid resuscitations. Now, excess fluid with increased capillary permeability can result in pulmonary edema and worsening of the lung injury. Now, the common phrase that is used is a dry lung is a happy lung. So the objective that we follow mostly is to keep the patient dry with a conservative fluid management strategy. That is the use of diuretics, that is Lasix infusions. You can combine it with albumin to remove more fluids in more hypotensive patients. And the largest trial, that is the FACT trial in this particular group, found a reduced duration of mechanical ventilation compared to liberal fluid approach. So conservative fluid approach is recommended. However, exactly what are the targets is still not clear. Now, how do we manage refractory hypoxemia? You have done everything what we have discussed till now. Still, the patient has hypoxia. Then there are certain rescue mechanisms which have been tried. The first one being the use of APRV. This is an inversion ratio ventilation with a pressure setting. It uses a continuous high positive pressure with intermittent release to allow expiration and carbon dioxide removal. It aims to recruit the lungs and allow spontaneous breathing. The next is the use of inhaled nitric oxide. The use of inhaled nitric oxide reduces the pulmonary vascular resistance in the ventilated areas, aims to divert more blood to the areas, thereby to the areas that are ventilated and perfused, resulting in improvement in the ventilation, perfusion, and oxygenation. However, the trials have been short, and the only benefit that we have seen is short-term improvement in oxygenation. So if your patient is having increased hypoxemia, despite all these measures, you can use inhaled nitric oxide for short-term benefit. Now, what therapies or interventions we have in future line for us? So as I had told before, these biomarkers and their antagonists have been tried in a lot of population, because most of the trial till now have not been successful in finding a therapeutic treatment for ARDS. We just have the prone ventilation and low tidal volume ventilation. Apart from that, we don't have any therapeutic outcome. So there are a lot of these therapeutic targets have been identified, and they have been used to reduce the inflammation, like steroids, mesenchymal stromal cells, the use of simvastatin. So I will just briefly tell about this. Now, many pharmacological interventions have been tried with no benefit. The unsuccessfully tried ones are the use of inhaled prostaglandins, statins, aspirins, surfactants, activated protein C, beta 2 agonists, and keratinocyte growth factors. Now, recently, there is a lot of study coming in from the mesenchymal stromal cells and their use in ARDS. A multiple stage 2 trials have been done with positive outcomes. These are multipotent cells which are being isolated from the bone marrow, umbilical cord, or adipose tissue, and they help in immunomodulation, reparative function, and antimicrobial action. Now, RCTs have shown they have proving their safe and efficacious. However, we need phase 2 trials. We are still in the phase 3 trials. We are still in the phase 2 trials. Now, therapeutic interventions like the HARP2 trial initially showed no benefit, but when we looked at the specific subphenotype of hyperinflammatory ARDS, there the simvastatin group showed to have a better 28-day survival. So we need to find our correct subphenotype and target our pharmacological therapy to that particular group. Now, for that, we need precision medicine in ARDS. It aligns with the therapeutic intervention with a treatable trait and focuses the translational research to find these treatable traits and match the therapy with it. Now, the existing data is to identify more patients who have a response to the treatment, because ARDS is a very heterogeneous population. Now, platforms have been created, especially after the COVID-19 research, to identify these things. Now, this is the platform, that is the International Precision Medicine Phase 2 trial for ARDS therapies. This may help us in future in identifying pharmacological treatments for ARDS. Thank you for your patience. That's all for the class.
That's a very good lecture, sir. Without any delay, I want to welcome Dr. Ropali Patnaik, ma'am, to talk on pneumonia and VAP.
Infiltrate with or pleural effusion and chest radiograph. What is severe community acute pneumonia? It is used to define a subgroup of critically.
The video is audible.
Yes, sir, it's audible.
From the starting, no?
Sir, in the starting few seconds were not audible.
Okay,
Then
I'm
it's
starting
audible, sir.
Very good afternoon, everybody. I am Dr. Rupali Patnaik. Today I will be discussing on community acute pneumonia and ventilator-associated pneumonia. First, we'll discuss on community acute pneumonia. Pneumonia is inflammation and consolidation of the lung tissue due to infectious agent. Community acute pneumonia is with onset that occurs outside an acute medical care setting. So it is a clinical diagnosis combining features of acute respiratory infection and new infiltrate with or pleural effusion on chest radiograph. What is severe community acute pneumonia? It is used to define a subgroup of critically ill patients affected with pneumonia with a disease severe enough that requires hospitalization in most likely higher level of care in the mainly intensive care unit, that is severe care. Coming to the severity criterion, the severe CAP is defined by either one major criteria or three or more minor criteria. The major criteria is septic shock with need of vasopressor support and respiratory failure requiring mechanical ventilation support. And these are the various minor criteria which include respiratory rate, PF ratio, multilobar infiltrates, confusion, disorientation, patients with uremia, leukopenia, thrombocytopenia, hypothermia, and hypotension needing fluid resuscitation. The patients with either one major or three minor criteria, they are defined by severe CAP. Then what are the risk factors for severe community-acquired pneumonia? Various risk factors are there. The demographics, like mainly low socioeconomic status, winter season, and age, male gender predominance, and genetic polyformation. Along with that, various organ comorbidities like cardiovascular system involvement, previous pulmonary conditions like asthma, COPD, bronchiectasis, chronic use of inhaled steroids, patients with debilitating neurologic conditions, immunosuppressed conditions like HIV, malignancy, chemotherapy agents, endocrine conditions, and diabetic patients, patients with CKD on maintenance hemodialysis, liver disorder patients, and most important, patients with history of exposure, patients with drug abusers, the alcohol, smoking history, and previous colonizers. These are the risk factors for severe CAP. Then what are the pathogens for severe CAP? The pathogens are mainly divided into gram-positive, gram-negative organisms and the less common organisms. The gram-positive most common is streptopneumonia, including drug-resistant streptopneumonia and staph aureus. So gram-positive, streptopneumonia and staph aureus, these are the major pathogens responsible for severe CAP. And in gram-negative bacilli, the Haemophilus influenzae, Klebsiella, Enterobacteriaceae, Legionella, and viruses are influenza viruses. In patients with specific pulmonary conditions like cystic fibrosis and pre-existing pulmonary diseases, Pseudomonas aeruginosa can be a causative agent. The less common organisms are Mycoplasma, Chlamydia, Coxiella boniti, Moraxella, Bordetella, Burkholderia, and anaerobic bacteria and other respiratory viruses also. In endemic areas, this can be tuberculosis and histoplasmosis, coccidiosis, blastomycosis in specific areas like in mainly North American areas. There are also some pathogens associated with bioterrorism. In pathogens with specific risk factors, we think patients with chronic COPD, smoking history, in previous influenza infection, and these patients are risk factor for streptopneumonia infection. Especially patients with previous history of antibiotic exposure, alcoholism, and immunosuppressive state, they are risk factors for drug-resistant streptopneumonia infection. The risk factors for staph aureus are mainly patients with IV drug abusure, patients with diabetes, renal failure, on chronic central venous catheterization for and maintenance hemodialysis. These are risk factors for staph aureus infection. And patients with skin infection and prior influenza infection, there are risk factors for community-acquired methicillin-resistant staph aureus infection. Obviously, COPD and bronchiectasis patients, the risk factors for Haemophilus influenzae infection, and Legionella mainly it occurs with outbreak. There is humid weather, exposure to there is the previous history of travel to some areas. Then these are risk factors for Legionella. For anaerobes, mainly patients with poor dental hygiene, periodontal disease, and alcoholism and aspiration history. There are various less common pathogens, and the associated risk factors associated with it are also described. Okay, but these are less common for community-acquired pneumonia. Like in exposure to birds, there is risk factors of chlamydia. Exposure to bed soil, there is chances of histoplasmosis and all that. Then what are the clinical features of CAP? The common clinical features like fever, chill, trigor, non-productive cough, pleuritic chest pain, shortness of breath, tachypnea. There are important non-respiratory symptoms alone. Not only the respiratory symptoms, there are predominant non-respiratory symptoms like headache, altered sensorium, seizure, nausea, vomiting, abdominal pain, diarrhea, and myalgia also. Long examination reveals dullness and percussion, increased tactile vocal tremitors, bronchial breath sounds, and ergophony. And what are the auscultation findings? It include crackles, whispering, pectoralici, ergophony, and pleural friction drops. These are the important auscultatory findings we get in patients with pneumonia. There are some specific clinical features like patients with chlamydia, mycoplasma, the complications like bullous meningitis, skin rash, pericarditis, hepatitis, hemolytic anemia, and meningoencephalitis can occur. Patients with bacteremia with staph or strepto, there can be metastatic manifestation like endocarditis, brain abscess, and meningitis. Obviously, clinical presentation may differ in elderly. It is very much important that in elderly, sometimes the non-respiratory symptoms predominate over the respiratory symptoms, which include acute confusional state, fatigue, lethargy, decreased appetite, and worsening of the pre-existing status. Then coming to diagnosis part of community-acquired pneumonia, most important is the radiology. What is chest radiograph findings? The chest radiograph suggests alveolar filling densities with air bronchogram, peribronchial infiltrates, diffuse ground glass changes, are common findings. The chest radiograph may be suboptimal in patients with early infection, bullous emphysema, obesity. These patients and CAP severity correlate radiologically with multilobar and bilateral infiltrates with cavitation and loculated pleural effusion. If these findings are there, then there is severe, high level of severity patients with more multilevel infiltrates, cavitations, and pleural effusion loculated, like can be due to empyema. The chest radiograph patterns are generally not useful for identifying the causation. These are the findings, but it is not helpful for finding the causative agent. For that, microbiology is needed. Pleural effusion can be associated with pneumococcus, streptopneumonia, and Haemophilus influenzae, and cavitations can be specific of like Pseudomonas, staph, anaerobic organisms, or tuberculosis. Then comes the chest CT scan. The CT scan is obviously a better sensitivity and specificity, but it has its own hazards like radiation exposure. It may patient, a critical ill patient, they need to be shifted to CT suite for this CT scan. And we have in our hand the long ultrasound. Long ultrasound is very much advantageous in patients with community-acquired pneumonia because it is repetitive tool. It is a non-invasive tool. We can repeat. It can bedside tool. No need to transfer the sick patients to outside settings, and also it has no radiation exposure. The findings of long ultrasound can be in the pneumonia. It can be tissue sign that lies compact mass without volume loss, or there can be thread sign that appears as interface between partially aerated alveoli and completely airless or fluid-full alveoli from the pneumonic process. This is the interface that lead to thread sign and the tissue sign. These are specific for the long ultrasound findings of the pneumonia, and there can be parapneumonic pleural effusions. The pneumonic infiltrants often contains dynamic air bronchograms. These dynamic air bronchograms are mobile, hypoechoic, punctiform areas due to trapped air bubbles within bronchi that move with respiration. So obviously, thread sign, tissue sign, parapneumonic effusions, and dynamic air bronchogram. These are the findings we get in long ultrasound. Then comes the laboratory and microbiological testing. Obviously, patients with pneumonia come, we have to send the CBC, RFT, electrolytes, LFT, and most important, the arterial blood gas analysis. Respiratory sample culture, blood culture, serology, not routinely advised, mainly in patients for epidemiological evaluation for atypical organisms mainly. Severe CAP, it is for legionella infection, then legionella urinary antigen, which covers the serogroup 1 to 10. Pneumococcal urinary antigen, sensitivity 50 to 80%, specificity is high in suspected pneumonia cases. PCR assays like viruses, mycoplasma, chlamydia, and mycobacterial tuberculosis, and other tests like immunofluorescence and enzyme immunoassay for viral antigens like influenza, parainfluenza virus, respiratory syncytial virus, and adenovirus. Biomarkers obviously no role in diagnosis. They can be helpful in prognosis, and serial monitoring can be helpful in diagnosis. Then comes the what are the guidelines for community-acquired pneumonia? There are two guidelines have come. One is like ATS and IDSA guideline, which came in 2019, and the recent came is the ESICM guideline, came in 2023. So guideline, what are they telling for sputum culture? They are recommending new guideline. They are recommending patients with severe disease as well as all empirically treated for MRSA or Pseudomonas. Then we should send the sputum culture. Also, blood culture is not routinely recommended. It is recommended in patients with severe disease and in patients empirically treated for MRSA or Pseudomonas aeruginosa. That is, patients with severe CAP, those who land up in ICU basically needing respiratory support. There we have to send the respiratory samples and blood culture, and we are treating them. If we are treating empirically for MRSA and Pseudomonas, then we should send the cultures and confirm it rather than continuing the empirical therapy. Then what are the guidelines telling about macrolide monotherapy? There is at present, it was previously a strong recommendation. It is conditional recommendation for outpatients based on resistance levels arised for that. And procalcitonin, obviously biomarkers not recommended to determine need for initial antibacterial therapy. Steroids, the 2019 this IDC guideline, they recommended not to use, maybe considered patients with refractory septic shock. And empiric therapy for severe cause, both accepted was stronger evidence in favor of beta-lactam or macrolide combination. Previously, it was like beta-lactam macrolide combination or beta-lactam or fluoroquinolones combination. But they are recommending beta-lactam and macrolide combination over beta-lactam and fluoroquinolone combination. Routine use of gest trigger, obviously, it is not recommended. And if there is obviously worsening and any deterioration in the clinical condition, then we should ask for the chest radiograph. Then coming to treatment. For treatment, first we have to decide the site of care, where to treat these patients. The various severity criteria is there for that. One is like pneumonia severity index, also known as POT score. Patient outcome research team score. Various parameters are there like demographics, comorbidities, physical or vital signs, and laboratory findings. This leads to there's a score. The score is more than 4 or 5. The risk class. Then we have to admit them to inpatient, and 5, especially they need ICU level of care. Then other scoring system like cough 65, everyone must be aware of, confusion, uremia, respiratory rate, systolic blood pressure, and age. The cough 65 score, if it is more than 3, then these patients have high risk of mortality and they need to be treated there in the ICU if it is more than or equal to 3. Other scorings like smart cough scoring system. It is like systolic blood pressure, multi-level involvement, albumin, respiratory rate, tachycardia, confusion, oxygenation status, and pH level. Patients with more than 7 score, they are basically more than 5 are high risk and more than 7 is very high risk for needing intensive respiratory or vasopressor supports. They should be treated there in the intensive care unit setting. Then comes the treatment aspect, treatment strategy with severity. There is non-severe inpatient pneumonia or severe inpatient pneumonia. Obviously, non-severe inpatient pneumonia is not our concern. Our concern is mainly severe inpatient pneumonia. Their standard regimen is beta-lactam plus macrolide combination or beta-lactam fluoroquinolone. Obviously, beta-lactam macrolides are more preferred. And patients with prior respiratory isolation of MRSA, if they have previous history of MRSA isolation, then we have to add the MRSA coverage empirically and obtain culture or nasal PCR to allow de-escalation or confirmation if there is still need for this empirical therapy to continue. In patients with prior isolation of Pseudomonas, there also we have to think for covering Pseudomonas aeruginosa, and then but we have to obtain culture to allow de-escalation or confirmation that we need to continue this therapy. Patient with recent hospitalization and parenteral antibiotic use and local validated risk factors for MRSA. If there is high prevalence of MRSA there in this hospital setting, they have recent hospitalization, previous history of parenteral antibiotic use over the last 3 months, then we have to add the MRSA coverage and obtain obviously cultures and nasal PCR, thinking for de-escalation and continuing the therapy. In patients with previous hospitalization, parenteral antibiotic use, and local risk factors and local antibiotic suggestive of Pseudomonas aeruginosa high incidence, then we cover Pseudomonas aeruginosa, and obviously along with that we have to send culture to continue therapy or to de-escalate. Then obviously various pathogens are there. They have to specifically target these. Beta-lactam, specifically penicillin-resistant organisms are coming to 3rd generation or 4th generation cephalosporins are mainly preferred. Beta-lactamase producing organisms, and for mycoplasma or Legionella, macrolide or fluoroquinolones are preferred. For chlamydia, coxiella, francisella, these are mainly doxycycline. And the treatments are mainly the along with antibiotics. What is needed is the respiratory support. Can be non-invasive ventilation, high flow nasal cannula, invasive mechanical ventilation, and ECMO. Not going into detail, it's a vast topic. And coming to the controversial aspect is steroids in community acute pneumonia. Obviously, the 2019 ATS guideline, they are not recommending steroids to continue, but There are various controversies are there regarding that, and various new literature is coming also. This is the new literature published in NEJM 2023, which is hydrocortisone for severe CAP, which is a phase 3 multi-center double-blind RCT of almost 800 adult patients with severe CAP admitted to ICU, where they continued in one group hydrocortisone 200 mg daily for either 4 to 8 days, then tap out for the next 8 to 14 days. What they got? The result was like at day 28, death occurred in 25 of 400 patients in the hydrocort group and 47 of the 395 in the placebo group, with absolute difference of 5.6%. And it is statistically significant that they got the mortality benefit with the hydrocortisone use. Along with that, there was no side effects like use of hyperglycemia is obviously more in the hydrocortisone group in the initial 7 days, but like GI bleed and other complications of steroids were not that much obvious. Then if these patients are not responding, a failure to respond, then we should think that there can be resistant organisms, parapneumonic effusions, or pneumonia is complicated into empyema. There can be associated nosocomial superinfection, and some non-infectious causes should be looked for also. Then the other metastatic infection, especially patients with staph or strepto like endocarditis, meningitis, arthritis, this should be emphasized if these patients are infected with these organisms. Or there can be exacerbation of the previous comorbid illness or intercurrent other illness or nosocomial infection can be there. Then comes the ventilator-associated pneumonia. What is ventilator-associated pneumonia? It is new or progressive radiographic consolidation or infiltration with signs of inflammation and purulent respiratory secretion in a patient with endotracheal intubation and mechanical ventilation for more than 48 hours. It is one of the most common ICU-acquired infection with incidence range from 9 to 27%, and VAP rate, there's huge variability in the VAP rate, but it is like 1.2 to 8.5 per 1,000 ventilator days. But the epidemiology changes globally. Obviously, VAP is associated with increased mortality, increased ICU length of stay, increased hospital stay, and increased cost of treatment. It is a marker of quality of care. The attributable mortality of VAP is very high, with various multi-center studies have shown that high attributable mortality with patients with VAP. Coming to epidemiology, the various large multi-center trials, they have found that the most common organism here is the gram-negative bacteria like Klebsiella pneumoniae and Acinetobacter. They are the predominant organisms for the ventilator-associated pneumonia, and very less common are the gram-positive bacteria like Staph and Strepto. The epidemiological outcome results have found that the VAP is like within 3.3 days. The mean interval between intubation to VAP is like within 3 days, within 5 days. There is high incidence of heart acquiring VAP is within 3 days of intubation and ventilation. A systemic review of have found that there is high incidence variability in the VAP rate. That is, it ranges from 40, even very high, 40 for 1,000 ventilator days, and a meta-analysis which included 8 countries studies, they have found that the VAP rate is like 24 per 1,000 ventilators. Here India is also included. The risk factors and pathogenesis of VAP, basically tracheal tube. This is the gateway to ventilator-associated pneumonia. There are various risk factors, non-modifiable and modifiable risk factors. Non-modifiable risk factors like advanced stage, emergent surgery, chronic lung disorder, heart disorder patients after trauma, unconscious during hospitalization, high severity scores, Apache 2 score, malnutrition, these are non-modifiable risk factors. The modifiable risk factors obviously need for intubation or unplanned extubation, self-extubation, which are high risk for ventilator-associated pneumonia. Supine body positioning, nasogastric tube, prior antibiotic use, and continuing sedation and paralysis, which are high risk factors for developing ventilator-associated pneumonia. Then what are the risk factors for MDR VAP? Risk factors for multi-resistant VAP are prior IV antibiotic use within 90 days, septic shock at the time of VAP, ARDS preceding VAP, 5 or more days of hospitalization prior to occurrence of VAP, and renal replacement therapy. These are the high risk factors for occurring MDR VAP. The risk factor for MRSA VAP is obviously prior IV antibiotic use in the previous 90 days and chronic nursing home stay. Respiratory Pseudomonas also same chronic hospital stay and use of IV antibiotics in the last 3 months. Then normal host defense, obviously there is prevention of this ventilator associated pneumonia. That's why tracheal tube is the gateway for the valve, because this normal host defense is like our anatomy, our cough reflex, mucus, the mucociliary clearance, every macrophages, leukocytes, immunoglobulins, complement, lactoferrin, basement membrane. These are the various various host defense mechanism which are based when you put the tracheal tube. That's why the tracheal tube is the gateway for valve. Then pathogenesis, obviously exogenous and endogenous pathogenesis. Our hands use of devices like in bronchoscopy, we use nebulizations, various exogenous factors, the supine body positioning. All these are risk factors for all these lead to development of valve. And endogenous are endogenous flora which leads to this trickle and go to the lungs and they leads to valve, and also the gastric secretions, also oropharyngeal and gastric secretions are the endogenous things. Coming to diagnosis, it is the criteria new or progressive radiographic consultation on infiltration, the signs of inflammation and coagulant secretion in a patient with endotracheal intubation for more than 48 hours with any two of the following. They have endotracheal intubation with two of the following like fever, leukocytosis, leukopenia, increased tracheal secretion and drop in oxygenation status. The various criteria are there. The Johansson criteria, the first came into picture. Then most important is the clinical pulmonary infection score. It includes the temperature, TLC count, oxygenation status, chest radiograph findings, the secretion, quality of secretion, and the culture data. If the score is more than 6, then highly suggestive of ventilator-associated pneumonia. Then this is the CDC criteria. Obviously, it includes radiography and the criteria tool like the microbiological and the clinical factors. They include there in the CDC definition of the valve. Then what to do when there is clinical suspicion of valve? For diagnosis, we have to send the endotracheal aspirate or bronchoalveolar lavage. Obviously, the European guidelines, they are still recommending bulk samples, but the IDSA guideline, they are telling endotracheal aspirate can be sent. And we have to start the empirical antibiotic therapy, but consider the proper, if you get the culture data, then we have to modify our things like definitive antibiotic treatment, that is for 7 to 10 days. Then most important is the how we time our things like microbiological samples that should be sent for microscopy examination. We should get the gram stain very much early. Then empirically we think our treatment. Then obviously with the definitive diagnosis, when you got the culture, we modify our targeted treatment. Then coming to treatment part, obviously on the early valve, the anti-pseudomonal beta-lactams without MDR receptor, without pseudomonas receptor, then amoxicillin clavulanase or third generation cephalosporin. Patients with late valve that would develop more than 5 days or receptors for MDR, obviously then this is the organisms will cover the third generation cephalosporin or carbapenems as per the basically local antibiogram or the resistant data of your center is most important. If their prior MRSA colonization and incidence of MRSA is very high, like 20% in the prevalence in the unit, then we have to empirical also start the MRSA coverage, Vancomycin linezolid is being preferred. Then known colonization with CRA organisms and incidence of CRA is very high, carbapenem resistant enterobacteriaceae. Then we should think for newer combinations like we are getting CRE organisms, even the new those who are very much resistant, then we have available with us the ceftazidime avibactam and the astronome combination also. The MDR receptors obviously are antibiotic therapy in the previous 90 days, hospital stay more than 5 days, current respiration, septic shock at onset of valve, ARDS preceding valve, and renal replacement therapy, previous colonization with MDR pathogens. Then these are the high risk factors for the MDR organisms. And then comes to prevention aspect, obviously. prevention valve bundle is everyone must be aware of. There are some parts like I'm just telling head and elevation is very much important. Then like various design cuffs, but it has no impact. It has been found. Then automated cuff pressure monitoring also, it may lower valve rate, but not that much important. Subglottic secretion drainage important very much. It may lower the valve rate. Oral care with chlorhexidine still unclear. Various controversial data are coming. This SDT and SOD likely lower, but is not for our ICUs having high resistant organisms. And other like stress or prophylaxis, they may even increase the valve rates. Okay, and valve prevention bundles, they may lower some of the valve incidents, but not that much beneficial. Most benefit is like here in the valve bundle is sedation, it's minimizing sedation and encouraging the early extubation, which is to get rid of the gateway to valve, that is the endotracheal tube. Then what is important for is take home is to audit our ICU to decrease the incidence of identify where to improve our areas, focus on limited intervention at a time when it is feasible, customize the valve bundle according to your setting. It is not universal for all. We have to customize our valve bundle, and we have to follow our local microbiology, flora, antibiogram, and resistant patient, and most important to educate our staff. Thank you.
This is a very good presentation by Dr. Rupali Patnaik, ma'am. Without any delay, I want to welcome Dr. Sachi Chaudhary, sir, Assistant Professor, IMS and Some Hospital, Bhubaneswar, Department of Critical Care Medicine. He is here to present the topic on ethics in intensive care and end of life. Sachi, sir, please share your screen and proceed with the presentation.
Is it visible?
Yes, sir. Your slides are visible. Your voice is audible. Please proceed, sir.
Okay. Thank you, Molly. Good evening, everyone. So today we are going to discuss about a very important aspect of critical care medicine, that is end of life care. Before going in detail, first we should discuss about a clinical scenario. Suppose a very old patient comes to you with a large bleed, intracranial bleed with multiple comorbidities, and patient has, of course, midline shifting is present. GCS is 3 out of 15, and expected that patient has undergone herniation also. And neurosurgery consultation was taken, and they said that it's not going to be helpful with any surgical intervention, so they are advised conservative management. Now, how we are going to approach not only the patient and also the relatives about the present status of the patient. So these are the steps we should follow. First, we should evaluate the patient, and we should first confirm the diagnosis by both clinical and radiological means. And we should be first confirm that whether herniation has already happened. And here multiple team approach should be followed. That means neurology, neurosurgery, and cardiology team all should be taken on board. Then joint discussion should be done. Then decision will be taken. So it's obviously multidisciplinary approach. And if the team decides that we need to take further investigation or further management, that should be taken. So here we should remember that all the involved doctors should be on the same page, because this is a very sensitive issue. Now, how we are going to process this thing? First, end of life care, it should not be reached hastily, should not be taken directly. First, we should prognosticate about the condition of the patient to the family members. Then joint meeting should be performed with the family members. And if any further investigation is required, then that should be performed. Then only final decision should be taken. And if there is any conflict, then those should be addressed prior to taking the decision of end of life care. Now coming to the topic proper. What is the definition of end-of-life care? It's an approach to terminally ill patients where the focus of care changes from curing or treating the disease process and prolonging the life to a holistic care or symptom control or comfort, dignity, quality of life, and quality of death. In short, the approach changes from cure to care. And end-of-life care is a human right. We should remember here that every person deserves a good, peaceful, and dignified death. So the first step here is acknowledging the medical futility. And here you should remember that neither the patient nor should be relatives in front of them. We should not use the word futility because it may be harmful than giving any benefit. And second step is recognition that death is approaching. What are the common terminologies used in this regard? Apart from end-of-life care, there is another term, palliative care, that we are very aware of, that in cancer patients, only supportive care is given. So at the time of diagnosis, mostly palliative care referral is best initiated. And what is hospice care? Is a type of palliative care done in a place where the patient is most comfortable. Like maybe at his home, or it may be a nursing home or a retirement center. So this is a diagram showcasing all the terminologies, what we use at what place. During the course of illness, first screening is done and diagnosis is reached that the patient is suffering from a disease which cannot be cured or the patient has not got many time. So initially the treatment approach was curative, that gradually changes to palliative approach. And finally, no disease-directed treatment is done and the end-of-life care is taken in the lasting career and the patient dies. And after that, we should take care of the bereavement of the family. Now, what are the objectives? First, why do we need an end-of-life care decision? As we know, if we do not take an end-of-life care decision, unnecessarily we are prolonging the life of a vegetative life of the patient. That may be a source of misery, not only for the patient, but also for the family members who are involved. Also, there is a lowering of dignity of death due to futile invasive procedures and unnecessary treatment. There may not be any chance of improvement or survival, leading to wastage of resources. It may be a significant burden for the family. Now, what are the objectives of good end-of-life care? To ensure that each patient achieves good death, irrespective of type and duration of disease and place of death. To focus on quality of life as well as that of death, each person is entitled to a peaceful and dignified death with freedom from pain and suffering. And right to palliative care is a human basic right. Now, who are the patients qualifying for end-of-life care? In patient where death is imminent, like the respecting death within few hours or days. Advanced, progressive, incurable conditions where death is expected within, say, a year. Frail patients and who have multiple coexisting conditions. That means that they are not going to be alive for next 12 months or so. And existing conditions that they are at risk of dying from the event of a sudden acute crisis. So these are the conditions like say cancer patients with median survival of 6 months or less, like almost all solid cancers. There is distance metastasis, venous thromboembolism or pulmonary thromboembolism episode is there. Brain mets are present, spinal cord compression because of mets is present. There is malignant pericardial effusion. Similarly, carcinoma of unknown primary origin. Patient is ambulatory and can care for him or herself but cannot work. Hepatic, bone or adrenal mets. Recurrence of disease after chemotherapy. Significant weight loss is present. In those conditions, we expect that median survival of the patient is going to be 6 months or less. So they are the candidate where we should think about end of life care. Now, what are the other long-term neurological conditions like injury or disease of the nervous system that will affect an individual for the rest of their lives? Acquired brain injury of any cause, including stroke, spinal cord injury, and other conditions like epilepsy, and other progressive conditions like multiple sclerosis, motor neuron disease, Parkinson's, or other neurodegenerative disease also fall in this category. So how to begin? First, when the disease-directed therapy is not possible in a person with advanced progressive disease. So prolonged coma without any reversible cause and certain catastrophic medical condition with multi-organ failure with no response to intensive management. So these are the patients when we should think of beginning end-of-life care treatment. Now, what are the criteria for initiating end-of-life care? First, clinical criteria, as we studied. Then, agreement criteria, consensus among the treating physicians that all potentially reversible causes are corrected and the patient is dying. The family understands that the patient has advanced progressive disease and is dying as a result of progressive irreversible disease process and its complications. And symptom criteria, out of the 8 given symptoms, at least 4 should be present, like semi-conscious or comatose, unable to take oral medications, patient confined to bed, unable or lack of interest in food or fluids, no response to questions, and no spontaneous verbalization, detached from the surrounding, failing vital parameters. These are the criteria for initiating end-of-life care. Now, what are the steps in EOLC? First, identifying the dying process, clear decision-making, initiating end-of-life care, the process of end-of-life care, scope of palliation, then after-death care, and bereavement care. We'll talk about them one by one. Now, what are the changes that occur during the dying process, like fatigueness, weakness, ischemia, pain, decreased food intake, weight loss, dehydration, decreased level of consciousness, inability to communicate, loss of sphincter control. So these are the pointers for poor prognosis and limited life expectancy. Now, what is interdisciplinary decision making? End of life care is delivered by a team that comprises of all other departments like neurology, surgery, cardiology, critical care team. So, it's a interdisciplinary team approach should be present, including the nursing staffs. And decisions should be made after discussion between all members of the team. And here we should remember that difference in opinion must not exist before taking the final decision. Now the most important part, communication between clinician and family. Here the primary physician who is caring for the critically ill patient, he should lead this discussion and prognosticate to the family along with other members of the team. Responsibility of the decision must be shared jointly by family and the physician. So first assess about the prognosis, then assessing family preference for this role in decision making, then adapt strategy according to patient and family factors. The final decision shared decision making. Now communications, we approach during communication various methodology. For instance, for non-verbal communication, solar approach is used. S transfers face the patient or family squarely at the eye level to indicate your interest and involvement. Adapt an open body posture. Lean towards the patient or family. Use eye contact and maintain a relaxed body posture. Another approach is value method. Here, value the statements by family members. Acknowledge family members' emotions. Listen to family members, understand who the patient is as a person and how decisions are made in the family, elicit questions from family members. In short, we have to be involved with the family members and we have to be very serious. We should show interest that we are genuinely concerned about the condition and outcome of the patient. Now, what is Spike's approach? This is used for breaking the bad news. First, setting up a proper environment, then perception, patient's family perception regarding the progress so far, and the understanding of the illness must be assessed before breaking the bad news. And one must confirm that patient wishes to receive information. So we should invite to discuss about the diagnosis and prognosis. Then knowledge regarding the illness and the likely prognosis are given to the relatives in their own language. Emotional support is provided by identifying the emotion that the patient or family expresses and by responding it to appropriately. Then strategy and summary. At the end of the meeting, one summarizes the current situation of the patient and explains the future plan for comfort care and documents the end of life care accurately. Documentation is very important. Now, in some cases, there occurs conflict about the decision. So conflict is broadly defined as failure to achieve a consensus on the goals of the care and related treatment at the end of life care, despite allowing time of at least 48 hours. So the conflicts are due to various factors, maybe patient or family factor, when the patients are afraid or relatives are afraid of what is happening unless the illness has affected the ability to perceive and think, wishing to continue living, but at the same time, patient doesn't want to suffer. And then depth of understanding of the situation because of some religious belief or educational background, family, spouse, parent, sibling, friend, who experience depersonalization, loneliness, emotional stress, quality of relationship with the patient, socioeconomic status, ethnicity, and religion. These are the patient or family factors. Similarly, physician factors like level of medical education, grounding in medical ethics, communication skills, ICU culture, patient's ability to pay. So these are the physician factors that may lead to conflict. And rest are environmental factors like society's expectation from medicine, type of hospital, risk management approach of the institute, accepted ethical standard, and legal guideline of the country. Now, what is advanced care planning? This relates to making this decision in advance about what kind of treatment one wishes to have. It includes features such as living will and do not resuscitate orders. So these practices are mainly used in Western culture. In our setup, these are not considered appropriate because of some religious belief and lack of education. They may be reluctant to engage in this out of fear that it may actually invite serious illness and death if we are doing prior planning. Now, what is the modalities of end of life care? Suppose we have reached at a general consensus that we are going to end the life or we will start end of life care. So, what are the modalities? Three modalities are mainly used. One is do not resuscitate. The second, withholding of life support or non-escalation of treatment, withdrawal of life support. What is integrated care planning? Integrated care pathway designed for patients at the end of life. Two methods are used mainly. One is Liverpool care pathway, another is palliative care for advanced disease. Liverpool pathway is used in UK and the one in USA. Liverpool care pathway is first reported in 1997. It was initially designed to improve care for cancer patients in the last 2 days of life. In 2003, this pathway became one of the three components of the end of life program of the NHS in the UK, and it has got 18 goals of care relating to symptom control, psychological, spiritual, and family support. According to this, discontinuation of non-essential treatments such as unnecessary medication should be done, like blood drawing should not be done, measurement of vital signs, conversion of oral medication to parenteral route, procedures to be followed at the patient's death, and bereavement support. What is palliative care for advanced disease? It was developed at the Beth Israel Medical Center in New York City. It includes frequent symptom assessment, provision of psychosocial and spiritual support, physician ownership with standard orders for symptom control, internal ICP for end-of-life care, improves documentation of care delivered, and may also improve symptom management in end-of-life care. As the management of symptoms during end of life care, we have decided not to escalate or not to resuscitate the patient, but we should at least take care of the symptoms. We should minimize suffering. So, patient near the end of life experience extreme symptoms like physical, spiritual, psychosocial suffering. Pain is the most prevalent symptoms near the end of life. Unrelated pain is a source of great distress for the patients and also the relatives. So, opioid analgesics are the standard of care for treating moderate to severe pain in patients with advanced illness. Alternate routes of drug delivery should be discovered or taken care. Patients near the end of life, they may not be able to swallow oral medications due to nausea. Patients in palliative hospice care also they have very difficult intravenous access because of frequent chemotherapy and all. To avoid multiple attempts at IV cannulation, we can use subacute infusions for pain relief. And transmucosal, sublingual, and rectal approach should be used in these cases. These are medications commonly used. Now we're not going in detail into it. Like so remember that broadly glucocorticoids, dexamethasone, prednisolone are used. Antidepressant like tricyclic antidepressants, SNRI, SSRIs are used. Similarly, topical agents like lignocaine pads or local anesthetic creams are used. NSAID, TCA are used. And for neurologic pain, gabapentins, pregabalin, oxcarbazine, lamotrigine, they are also used. And sodium channel blockers, GABA agonists are also other commonly used medications for pain relief. Next is dyspnea, is a subjective sensation of breathlessness, frequent and distressing symptom in a dying patient. Opiates and benzodiazepines are the most widely prescribed medications for treating dyspnea. As death approaches, continuous infusion to manage symptoms and relieve suffering, if scheduled or as needed, doses are not adequate. Treatment is either aimed at reversing the cause of dyspnea, like thoracentesis, or symptomatic management. So, and low dose opiates in refractory dyspnea support their safety and efficacy. And restlessness is associated with delirium at the end of life. Delirium and restlessness at the end of life characterized by anguish, anxiety, agitation, and cognitive failure. So the treatment of terminal delirium requires the use of major tranquilizer like haloperidol. Nausea, vomiting, for that we use ondansetron, dexamethasone, a neurokinetic antagonist apripitant. For bowel obstruction, patients with big abdominal tumors most commonly develop bowel obstruction. First-line treatment includes medical management with steroids and octreotide, and surgical outcome, if unless very or severe or we're expecting some amount of life is left, then we can consider. Otherwise, surgical correction should not be undertaken. And gastrostomy tube is an option in those patients. Then artificial hydration and nutrition, patients who are unable to take food or fluid. And decision to administer artificial hydration fluid is difficult to physician and patient party due to religious beliefs. Symptoms of hunger are less common during dying process. So the administration of artificial hydration and nutrition associated with risk of fluid overload leading to choking or edema. Additional risks associated with gastrostomy tube like dislodgement and increased need of restraints also attributable to their agitation. And then depression and anxiety similarly. They should be taken care by contacting or taking help of psychiatrist. For the anesthesiologist, recognizing depression, making a referral is important. Also, you should remember that depression affects pain management and quality of life. So, treatment for depression vary by life expectancy. Most commonly, SSRI and monoamine oxidase inhibitors are used. Now, what is death rattle? As responsiveness of the patient decreases towards the end of life, it becomes difficult for the patient to control or swallow oropharyngeal secretions. So, death rattle of the actively dying is the sound of air movement across pooled secretion in the mouth. So, it's not a cause of suffering for the dying person, but it can be very disturbing for loved ones to hear the sound. And so, how is it managed? By repositioning the patient's head and using anticholinergics like atropine, scopolamine we can manage this thing. Now, what is do not attempt resuscitation or DNR? According to American Heart Association guideline, this order is given by a licensed physician or alternative authority as per local regulation and must be signed and dated to be valid. In many settings, allow natural death is the term used in place of DNR. The DNR order should explicitly describe the resuscitation intervention not to be performed in the event of life-threatening emergency like cardiac arrest. So what are the do's and don'ts? First, what is done and what is not done. Even with DNR orders, a health worker will provide the basic support in form of like clearing the airway or suctioning, provide oxygenation, position, splinting, control bleeding, provide pain medication, emotional support, and contact hospice or hospital if available. And with DNR orders, a health worker is not supposed or not required to perform any chest compression, insert any advanced airway or intubation, administer cardiac resuscitation drugs like adrenaline, provide ventilator assistance or defibrillate. Those things should not be done. Next, what is support withdrawal? Pace of withdrawal of life-sustaining measures we individualized for each patient. Usually, vasopressor and inotrope should be discontinued first, which is followed by withdrawal of mechanical ventilation. Life-sustaining treatment should be withdrawn in a stepwise manner, ensuring alleviation of pain, respiratory distress, or anxiety at step. Monitoring that is not aimed at achieving comfort also should be discontinued. Now, what is after death care? The care process doesn't end with the patient's death. After death also, the bereaved family should be dealt sensitively in a culturally appropriate manner. Should be provided all logistic support such that the deceased person is transferred out from the hospital in a timely and dignified manner. Should not be in a hurry in these situations. Then bereavement care support should begin with identifying high-risk individuals or family members much before the patient's death. Should be identified actively and addressed. Referral to a psychologist or psychiatrist should be initiated on a need basis. Now, in all these things where India stands, Lion Foundation ranked end-of-life care service in 40 countries. The outcomes of quality of death index showed that India is ranked 40 out of 40 in end-of-life care overall score. India's position is 37 out of 40 in basic end-of-life healthcare environment, 39 out of 40 in cost of end-of-life care treatment, 35 out of 40 in availability, 37 out of 40 in quality of end-of-life care. And score 2 on a 1 to 5 scale on public awareness of end-of-life care, where 5 being the highest score. The legal position in India, actually, though there is no legal guidelines. So a petition was filed by an NGO named Common Cause for declaring the right to die in dignity as a fundamental right. In response, the Chief Justice of India has appointed a 5-judge constitution bench to look into the issue around euthanasia and death in dignity. The Indian Society of Critical Care Medicine also has filed an implement petition as a party respondent in the above petition. Now, coming to ethical aspect, ethics of end-of-life care is an integral part of ethics of critical care is to decide who needs treatment in ICU and when the treatment is no longer indicated. Patient autonomy or respecting the patient choice is the cornerstone of this decision making. So 4 core values are there in ethics. First is autonomy. The patient has absolute right to choose or refuse any treatment. Beneficence, doctors should act in the best interest of the patient. Non-maleficence, first, do no harm to the patient or their relatives, and justice. There is equal distribution of the resource should be there. There are complex legalities are present still. Comprehensive and clear guidelines or recommendations are still to come. Appropriate education and relevant service provisions to take care of the terminally ill and dying patient. Modern methods of pain control are available, but it is assessed by only 3% of the population. Improper pain reliefs leads to violation of principle of beneficence. But here the ethical dilemma lies when analgesics are used in sufficient quantity to relieve pain that might lead to quickening of the death. So the doctor is protected against litigation regarding these matters if acting in the best interest of the patient. For this purpose, Indian Society of Critical Care has laid down certain guidelines to deal with these issues. Now, what are the guidelines? First, the physician has a moral and legal obligation to disclose to the capable patient or family with honesty and clarity the dismal prognostic status of the patient with justifications when further aggressive support appears non-beneficial. Guideline 2, when the fully informed capable patient or family desires to consider the overall treatment goal of comfort care only option, the physician should explicitly communicate the standard modalities of limiting life-prolonging intervention. Guideline 3, the physician must elicit and respect the choice of the patient expressed directly or through his family surrogates during family conferencing sessions and work towards shared decision making. Guideline 4, pending consensus decisions or in the event of conflict with the family or patient, the physician must continue all existing life-supporting intervention till the conflict is cleared. Guideline 5, details of the communications between the medical team and family should be documented accurately and completely. And final, if the capable patient or family consistently desires that the lab support be withdrawn or that he or she should be discharged home to die in situations in which the physician considers aggressive treatment is non-beneficial, then the treating team is ethically bound to consider withdrawal of the life support modality in question, although clear legal guidelines regarding this are still lacking. A withdrawal or withholding decision should be implemented after completing a life support limitation form duly signed by the patient's family and the treating team. So the take-home message, there are no guidelines on withdrawal of care or end of life decision accepted by the government till now, judiciary, professionals, academicians, or the community. Consensus within healthcare team needs to be achieved before discussion with the family members. At the end of discussion, a summary of the discussion should be prepared and signed by the next of kin and the unit in charge or treating doctors. And the DNR order should be reviewed in the event of unexpected improvement or on request of next of kin. Same should be documented properly. Thank you for your patient hearing.
That is a very good presentation, sir, Sajid sir. So, before going to the next presentation, sir, what are the recent recommendations by ISCCM regarding end of life? So, the physician should respect the patient attender's words, and if there is any conflict, till the conflict
till
is
any
clear.
conflict is resolved, we should continue with the treatment that is already going on. We should not stop basic treatment
If there is any
till
conflict in the shared decision making, we have to proceed to in treating him as like any other normal patient.
Yeah.
So withdrawal, we have to begin withdrawal only after the consent is duly signed.
Yeah,
As a part of SDM.
yeah. If the patient is fully aware, then he should sign. Also, the next of kin or the family members all should come to a conclusion. Then only we should proceed with end of life care.
Okay, sir. Okay. Thank you, sir. Without any delay, I want to welcome Dr. Biswajit Naik, sir, to present the next presentation, that is evaluation of the brain death in ICU. Biswajit, sir, please welcome.
It's audible?
Yes, sir, it's audible, sir. Your slides are visible.
Okay.
Please proceed.
The next chapter is evaluation of brain death. So this first concept is originated from Mollack and Gordon when the patient is in a state beyond the coma. So in 1968, the ad hoc committee at Harvard Medical School re-examined the definition of brain death. And in 1976, the Conference of Medical Royal Colleges proposed the clinical diagnostic testing. American Academy of Neurology in 1995 proposed the parameter for the diagnosis of the brain death. In India, in 1994, the brain death is legalized under the Transplantation of Human Organ Act, and we follow the UK criteria for brain death. When the deceased person means a person in whom permanent disappearance of all the evidence of life occurs by means of brainstem death, or in a cardiopulmonary sense, that when at any time after the life has taken place. In these two cases, we can, when the patient is having permanent system of the concern, life concern. So the criteria include irreversible coma, irreversible coma, or brainstem reflex must be absent, and apnea. So coming to before the request to mention, we should know the history, physical examination, investigation for the cause of the irreversible brain function, and the confounding factors in the declaration like shock or hypothermia, neurotoxics like venation, brainstem encephalitis, GPS, encephalopathy, severe hypophosphatemia, drugs like muscle laxant or anesthetic drugs. So that requires complete visual examination. Response to nexus stimuli through the cranial nerve pathways should be abolished, and sites for the nexus stimuli is supraorbital group or trapezius squeeze. Now, come to complete visual examination, there is must be absence of direct and consensual light reflexes, but this is inconclusive if there is orbital trauma, head injury, cataract, or any medications like mediatrix. And there is must be absence of the corneal reflex, oculocephalic reflex, oculovestibular reflex, cough and gag reflex, and that oculocephalic reflex is actually when we move the turn the head to side, the eyes also move with the along with the head. This is a normal reaction. If the eyes remain in a fixed fin skull with respect to skull, then there is Brenton death. So if you turn to right, then the eye will also turn to the right side. And if you turn to left, it is turn to the left side. And then it's Brenton death. Coming to oculovascular reflex, it's also called caloric test. The prerequisites are external auditory canal must be clear of cerumen, the tympanic members must be intact, and head rate should be more than 30 degrees. The procedure is we must irrigate 51 of ice water in the external canal and look for the eyeball movement. And that's a 1 minute response time. And we must at least 5 minutes between the testing of each side. And no ball eye movement is signified that penetration death. Now, second is apnea test. The prerequisite for apnea test is the core temperature must be more than 36.5. Patient will be euvolemic. PCO2 is normal. PO2 is also more than 200, and constant is not needed actually for doing apnea test. So what do we do? First reactionate with 100% oxygen for 10 to 15 minutes. Take a baseline ABG. Discard the ventilator. Ready for 4 to 6 liter oxygen via soft catheter to the ET tube, and observe any respiratory movements. Then after 8 to 10 minutes, do another ABG to look for PO2, PCO2, and pH. And if there is any respiratory movement, then the test stamp as negative. And we should click on the ventilator if there is fall in BP or significant desaturation or any arrhythmias. So intervention when the test is positive, when if it is a patient has the respiratory movements and PCO2 is more than 60 or change in PCO2 is more than 20. And test include indeterminate if its PCO2 is less than 60 and PCO2 is less than 20 millimeter rise from baseline. Now coming to ancillary test. These are not routine tests, but it is indicated when the patient has cranial or cervical injury or cardiovascular instability, whether we can do the perform the reflexes like oculocephalic, oculovestibular reflexes. And in case of severe facial trauma, rotorrhea, so we can do the oculovestibular reflexes and perform the corneal visual pupillary reflexes. So this is preclude performance of a person of a clinical examination. And also, if there is a doubt or disagreement in the diagnosis, then we can do the ancillary tests. What are the ancillary tests? These are EEG, cerebral angiography, transcranial scintigraphy. These are not replacing that clinical assessment. So clinical assessment is the first. Then, if it is doubt, then we can go for the ancillary test. So the act is not doesn't mandate the use of the ancillary test. So coming to first four vessel cerebral angiogram, where we get absent of any cerebral circulation, and it is the gold standard from the in between the ancillary tests. And CTM MRI angiography is not recommended. Techniques of 99 showing the hollow skull sign. It is a normal, and here is the hollow skull sign. Into EEG is the most commonly used test, where we get the loss of bioelectric brain activity for 30 minutes. After 30 minutes, you will not get any brain activity, and measured by the 16-inch channel EEG. But the disadvantage is affected by the hypothermia and drugs. Not only sensory epoch potential, SSCP, and brainstem auditory epoch potential, where we get no responses. And the conventional angiography, there is no intracerebral feeling at the level of carotid bifurcation or circular pulleys. It is the normal, where you get from the base, it is the where there is no flow. In the mentioned, showing the mentioned there. Transcranial Doppler, when there is in the cause is the ICP, so there is we get no small systolic pressure without diastolic flow, or where we get the reverberating flow. But the problem is the difficulty finding the temporal insulation window. So now the T, that is the four doctors must be required to diagnose such a brain tumor. First is the medical superintendent of the in charge of the hospital. Second is the doctor of the patient in charge of the patient. Third one is the neurologist or neurosurgeon from a authority panel. And fourth one is the a specialist from other department approved by the authority. But in 2011 amendment, it is also the declares can be done by the two doctors. Like one is the physician or surgeon, or another is anesthetist or internist. If only neurosurgeon or neurologist on available, and they must be fill up the form 10 for certification of the brain death. So, if there is a clinical examination and apnea test must be done twice after with the interval of 6 hours. All the four doctors should sign the test done to document the absence of the ventilation function, and the time of death in patient is the end of the second apnea test.
This is very nice presentation, sir. So without any delay, I want to welcome Dr. Sanjeev Dar, sir, Assistant Professor, Department of Critical Care Medicine, IMS and Sam Hospital, Bhubaneswar. Sanjeev, sir, please take over. Sanjeev, sir, you can share your PPT.
Is it visible now?
Yes, sir, it's visible and your voice is audible. Please proceed, sir.
Okay, just 1 minute. So I am after the how to evaluate organ donation, brain death patient. I am presenting this topic: how to manage subsequently a brain death patient for management of organ donor.
Sorry for interrupting. Kindly make it full screen, sir.
Is it visible now?
Yes, sir, it's visible. Please proceed.
So, how to define a brain death? Brain death patient is a potential organ donor. This is defined by the presence of either brain death or catastrophic injury to the brain, which could be progress beyond the reversibility. That is a definite cause. So, if we see the incident, India, our organ donation in India is very less, that's 0.8 per million in comparison to other countries. So, what are the people? Things that is, there should be established cause for brain death, and there should be any absent brainstem function. The brainstem function should not be there, and apnea test in apnea test PCO2 should be more than the diagnostic criteria. So, what are the preconditions should be there? The core temperature must be more than 32 degrees centigrade. Metabolic parameter like ml equivalent, that is sodium should not be more less than 130 to 130, or that should not be more than 160 to 170. And acid base balance should be normal, and there should be no endocrine disease. Was depend later modified in 2024. So I have already described this. The criteria for declaration of brain is good, the irreversible cause of coma, and brainstem reflex should take injury, how anything, how the brain is suffered, and physical examination, investigation of the etiology of the brain dysfunction, irreversible brain dysfunction. Simultaneously, you have the confounding factor like if patient having shock or hypotension must be the low sensorium. So any hypothermia, that's the patient also must be in coma or altered. Criteria, physical examination, one should do the apnea test, as I already described before. And simultaneously, ancillary tests, these tests are not mandatory as per the Indian law. This is not mandatory for doing the clinical examination. Apnea tests are only confirmatory. And ancillary tests that we do, there are EEG, cerebral angiography, transcranial Doppler, scintigraphy. But these do not replace the clinical assessment. Transplant human organ does not mandate the use of ancillary tests in India. So these are some of the exclusion criteria of organ donation. Lymphocytic virus or the absolute contraindication, or a patient having hepatitis B or C seropositive. These are the contraindication, but not absolute contraindication. Patient having hepatitis B or C can donate. Patient having a hepatitis B seropositive recipient. So bacteria and bacterial sepsis, these are again not again absolute contraindication. Because pathogen, we can give pathogen specific antibiotic for at least 14 hours before the organ donation. So this is not absolute contraindication. Again, viral infection, measles, rabies, adenovirus or parvovirus, and herpetic meningococcus. These are some of the exclusion criteria. Active malignancy like patient having melanoma or choriocarcinoma are again the exclusion criteria. If there's ongoing febrile illness, encephalitis, or meningitis that's giving rise to coma, this should be again an exclusion criteria. So after the examination, apnea test, and excluding the criteria, we should properly document the findings. So certification of mentioned that panel of should be done by panel of 4 doctors, as I described already, and one should do the clinical exams, apnea test, and all should be documented properly. Etiology and irreversible cause of coma and fondness for illness, absence of motor response to pain, or absence of resistant reflex during 2 separate examination, 6 hours at least 6 hours apart, and absence of respiration with PCO2 rise up to more than 60 millimeter of mercury. That is the apnea test and the justification and result of confirmatory test if used. The ancillary tests if used, all this would be documented. After documenting, then the this is third organ donations actually there is a process for the organ donation. So the role of intensivist here is to communicate to the donor coordinator team. The treating physician, the treating physician or ICU intensivist should not directly communicate to the relative for the organ donation. This is organ donor team is separate, and the ICU physician should communicate it to them, and the organ donor team should approach the patient or patient approach the patient relative for organ donation. So after giving the once the organ donor team communicated to the patient relative, then the ICU physician should communicate to the hospital administration so that further bill should not be generated, or further bill should not be billing should not be done for the patient. So communication subsequently should be noted. If the patient have already given disease consent, the himself has given consent, that should be recorded before, so that act as a self consent for the organ donation, or next to kin can give the consent, or control consent can be taken in medical legal cases. So what are the pathophysiology of blood death? The cardiovascular, initially in breast and death, they are initially occur transient, the catecholamic storm. So there is transient rise initially the hypertension and blood pressure. Subsequently, there occur the storm when stops, there occur hypertension and bradycardia. So initially there is hypertension, bradycardia sometimes reflex bradycardia can happen, and catecholamic storm that's occur. That gives rise to sympathetic stimulation, and it that causes increased vasoconstriction and increase in afterload, and increase the or increase systemic vascular resistance, and catecholamic causes increased tachycardia. So catecholamic storm occur. This gives rise to central redistribution of blood and increased afterload, and visceral ischemia, is a vasoconstriction, and also acute myocardial injury can occur during the catecholamic storm. So this is a transient catecholamic storm is a transient for transient time. After that, again hypotension ensues. This is because there is loss of the sympathetic tone. This sympathetic tone loss because of the spinal cord ischemia, and the spinal cord that supplies the sympathetic to the heart. That again the sympathetic discharge decreases, so there occurs the loss of hypotension. So simultaneously, sometimes because of we use the diuretics that can cause hypertension. Hyperglycemia induced osmotic diuresis and fluid loss. Diabetes insipidus, sometimes patient lose lots of urine, salt-free urine, so that again gives hypertension and hypothermic cold diuresis. So patient sometimes suffers from hypothermia, and that again itself is a cause of high urine output. So again, hypertension because of inadequate fluid association and decreased oncotic pressure after crystalloid resuscitation, and ongoing blood loss sometimes happen because of injury, and rearranging patient again causes the vasodilation, subsequently hypertension also. In the respiratory, the pathophysiology changes are patient may develop pulmonary edema. This may happen because there is of a pulmonary hydrostatic pressure, and sometimes there is increased capital permeability. So because of endogenous norepinephrine, that again externalize the fluid, accumulates the pulmonary edema. Patient may progress to apnea or cardiac arrest. Some endocrine disturbance also occur. Some common are the diabetes, most common is the diabetes insipidus, and also the patient lacks the insulin, so insulin resistant to insulin, so hyperglycemia can occur also. So in patient may have a diabetes So because there is posterior pituitary dysfunction occur in breast and brain death patients. So but anterior pituitary usually preserved. So posterior pituitary usually secretes the antidiuretic hormone. So there occur with loss of pituitary dysfunction, IDA secretion decreases. So there occur increased output more than 200 ml per hour for 2 consecutive hours. This is the diagnostic of diabetes insipidus. Then subsequent patient may have hypovolemia or hyponatremia because of sulfuric water loss in the urine. And as I told, antibiotic is preserved. So patient also endocrine dysfunction that the thyroid dysfunction occurs, thyroid, and hyperglycemia because of insulin concentration decreases or there resistance in the insulin. Resistance to insulin. So temperature again, there is loss of hypothalamic control of the body temperature, and hyperparaxia initially occur because of the catabolic storm. So the other causes of hypothermia are the reduction in basal metabolic rate or muscle activity, and peripheral vasodilatation, and because of loss of the sympathetic tone, and excessive heat loss, and administration of cold fluids to the patient. So this kind of brainstem death is an inflammatory process. And there are in this inflammatory mediator because of the damage to the brain also. Because of ischemia, again ischemia, when there is reperfusion injury, again that gives rise to increased inflammatory response. And then catecholamic in search against stroke, again itself is itself gives rise to inflammatory inflammatory mediators. And a failure to restore the normal cardiovascular state or homeostasis, you can give rise to inflammatory mediators. Coagulopathy also occurs because of there is an increase or release of the tissue thromboplastin from the necrotic brain, and also pro-inflammatory cytokines like interleukin 6. And brain death from the other pathology can contribute also to disseminated intravascular coagulation, and dilutional coagulopathy, again because of giving lots of fluid, the patient can also dilute coagulopathy, and hypothermia itself is a cause of coagulopathy. So what are the goal for management of an organ donor patient? So rule of 100 must be followed, and we should maintain the physiology close to normal level. That is the rule of 100. The systolic cardiac pressure should be maintained 100 mg/L. Urinary output should be at least 100 ml per hour. Partial pressure oxygen 100 mg/L. Hemoglobin concentration should be 100 gram per liter or 10 gram per deciliter, and blood sugar 100% normal should be there. And what are our general goal in managing a organ donor patient? Hand hygiene should be there, skincare should be there, dressing should be changes when necessary, because otherwise that could be a potential source of infection. Urinary and intravascular catheter management should be there, and the bronchial toilet and eye care. But we should monitor in a patient with a potential organ donor. So we should do ECG, blood pressure, pulse oximeter, core temperature monitoring, hourly urinary output, and central blood pressure monitoring should be there. And bedside echocardiogram should be done to assess the fluid if patient needs that. Again, some catheter or cardiac output monitoring, invasive cardiac output monitoring should be done if patient is unstable donor or persistent acidosis, or evidence of tissue hypoperfusion is there despite the basic hemodynamic monitoring. But investigation they can do on the atal APG, lactate, electrolyte, and blood sugar 4 hourly, and complete blood carbon, urine analysis, LFT, RFT, coagulation profile, and blood grouping. So simultaneously, we should do also screening with hepatitis B, C, and hepatitis HBsAg antigen, and HIV, IgM, IgG for cytomegalovirus. Blood culture should be and urine culture should be done if there is evidence of infection and the patient is hospitalized more than 72 hours. So additional tests, serial echocardiography if patient is a potential heart donor, and bronchoscopy should be done if the patient is a potential lung transplantation donor. So how would go about the temperature management? Active warming to maintain the temperature more than 35 degrees centigrade, and surface warming for all patients with a hypothermia should be given. Body temperature if less than 34 degrees centigrade, patient should be given in warm and humidified inhaled gas or fluid warmer. And cold preservation of organ. Cold preservation of organ storage should be done after interval of the organ. So cardiovascular support and food management, the goal are to maintain the normal bulimia and normal blood pressure, and optimize the cardiac output, maintain perfusion pressure of all organs with a minimal vasoactive support. So hypertension, if patient with these goals, if their patient is having hypertension, antihypertensive we can give, but antihypertensive usually is not required. If at all required, then we should give short-acting antihypertensive like esmolol, hydrogen, labetalol, nitroglycerin, or sodium nitroxide. If patient has hypertension, then volume expansion should be given with a increased steroid and a vasopressor and iron drops, and should be given, and patient sometimes require the hormonal replacement. So volume expansion, again the balance pulse solution. We should avoid hyponatremia because this patient already have hyponatremia because of pre-water loss. And then again, excessive normal saline give rise to hyperchloremic acidosis. So we should avoid normal saline in excess. And the hyperglycemia management, we should avoid hyperglycemia and hypothermia. So how to assess the food response? We should do bedside echocardiography, pulse pressure variation. These are some of the cardiac output monitoring, and urine output 1 to 3, 3 ml per kg per hour should be there, and the cardiac index should be more than 2.5, and central of saturation SCBO2 more than 70%. Vasopressor any target systolic vasopressor we should give with a target of systolic pressure more than 100 milliliter of mercury or more than 70. And vasopressin dose should be given up to 2.4 units per hour. The dose is different from the diabetes insipidus dose. And this use of vasopressor reduces the other vasopressor requirement, that is the norepinephrine. And norepinephrine high dose should be applied, that is more than 0.05 mics per kg per minute. Again, the other cardiovascular for management, the hormone replacement therapy. T4 is the 300 to 400 microgram should be via the nasal tube, and if it should be given if patient is hemodynamically unstable, but observation and clinical effect are not yet proven. And prevention of arrhythmia by electrolyte correction, management of blood pressure, fluid volume replacement, and body temperature normalization. And tachyarrhythmia should be we can give famotidine and cardiac motion and bradycardia, adrenaline, acetylcholine, patient as required. Ventilator respiratory system management. Ventilator managed by lung protective ventilation. Tidal volume is set by 6 to 8 ml per kg. Optimal to follow the minimum FI2. Liquid management after apnea testing or tracheal suctioning. And tracheal cough pressure should be maintained about 25 centimeters of water. Head elevation. Avoid excessive avoiding food overload or directive if required. Hormone replacement should give hormonal replacement therapy if patient is hemodynamically unstable or ejection factor is less than 45 degree or patient is a potential heart donor. And drug usually we give the vasopressin 1 unit bolus of followed by 0.5 to 4 unit per hour. And desmopressin we can give intranasally. So patients sometimes have a corticosteroid deficiency. So we should replace with the corticosteroid methylprednisolone used 15 milligram per kg per day immediately after the diagnosis of brain death, and subsequently every 24 hours. 15 milligram per kg per day, or 250 milligram followed by 100 milligram per hour till organ retrieval. Patient have hyperglycemia, again we should use insulin, IV insulin to target blood sugar 80 to 150. Thyroid hormone, usually we don't, in India we don't have the IV formulation, only we have the oral formulation. T3 doses are the thyroxine 25 microgram bolus followed by 10 mics per hour infusion. T3 4 microgram bolus followed by 3 mics per hour infusion. Or orally we can give 300 to 400 mics every 8 hours. So diabetic patient usually because of posterior risk person have the diabetes insipidus. So our acetol urine should be 330 to 200 ml per hour, not more than 200 ml per hour. And sodium level should be maintained 135 to 145, and fluid loss in urine is replaced by balanced solution or fluid with low sodium content. And patient with diabetes insipidus, we can give respiratory 10 mics for nasal puff. So we should give 1 to 2 puff every 4 hourly. And vasopressin IV 0.5 to 2 units unit per hour infusion. Infection management and nutrition, routine antibiotic prophylaxis is not warranted. Antibiotic based on the transient and culture positivity should be given. Nutrition as per the standard ICU protocol should be continued. So organ specific consideration, cardiac donor, usually patients to be less than 60 years, donor more than 41, we should do the coronary. Every patient more than 40 years, we should do coronary angiogram, and we should assure that there is no coronary disease, no history of patient shouldn't have any previous heart disease, and echography, cardiography should suggest a good cardiac function and no anatomical abnormality. So in cardiac donor, we should maintain the good hemodynamic, not on high patient should not be on high dose of inotropes. In cardiac arrest patient, donors recovery can be considered if the cardiac function is absolutely normal. We should do serial echocardiogram to monitor the response to medical management when early cardiac dysfunction is detected. In cardiac dysfunction patient, we should give the hormonal replacement therapy again, and arrhythmia should be managed with ACLS guided. In kidney donor patient, routine renal biopsy is not indicated. Radiographic assessment for the donor should be should be done when there is family history of polycystic kidney disease, or history of kidney stone, or history of urological anomalies. I should be given again to maintain the eupolemia. We should assess the ongoing fluid loss and electrolyte disturbances. Again, liver donor, hemodynamic status should be optimized, and our future marks should be targeted. Vasopressor again, that does not reduce the ability to use the organ. And a nucleus support as usual we should continue, and ultrasound not routinely required. In long donor, this patient should be less than 55 years, and patient should not be in active sepsis or malignancy in the lung or outside the lung, and there should not be no history of a significant chronic COPD, chronic obstructive pulmonary disease, and a chest X-ray clear lung filled without any evidence of trauma to the lung. ABG, after 5 minutes of 100% oxygen and a peak of 5, PO2 must be 300 millimeter of mercury to recognize the healthy organ, healthy organ in the donor. And the patient, as far as smoker is concerned, smoking history should be less than equal to 20 packs per year. So in lung donor, bronchoscopy should be done when there is upper aspiration or infection or therapeutic area for therapeutic area clearance. And I discussed that should be lung protective ventilation and fluid management as per the ISO protocol. Neutral or negative fluid balance, the patient should not be fluid overloaded, and blood pressure should be maintained with vasopressin. Small bowel generally we should avoid flowing things with the donor patient. If patient having excessive vasopressor requirement, and patient having prolonged cardiac arrest or circulatory death, because in this patient there is decreased sparkling circulation, so decreased circulation for prolonged time to the intestine. So in this patient, we should avoid thus intestine donation. At presence of gastrointestinal bleeding or hem positive stool, these are the contraindications to small bowel donation. And then our tube should be continued. Broad spectrum prophylactical antibiotic can be given depending on the local protocol. So this is all about the management of organ donor. Thank you.
That is a very detailed explanation, sir, regarding management of organ. I want to welcome Dr. Rupali Patnaik now to present on how to approach a respiratory case. Thank you.
Mistake.
Sir, the
Sir,
voice
video is not audible.
voice.
Very good evening, everybody. I'll be talking on how to approach a respiratory case. Then what are various respiratory failure and their types? The acute respiratory failure is inability of respiratory system to meet oxygenation, ventilation, or metabolic requirements of the patient. The respiratory failure is divided into two main types. Type 1 is hypoxemic respiratory failure or oxygenation failure. Type 2 is the hypercapnic or ventilatory failure with or without hypoxemic respiratory failure. I am not telling other respiratory failures here for clinical point of view. Most important is this type 1 and type 2. The type 1 respiratory failure, PO2 is less than 60 mmHg, and type 2 respiratory failure only when it is PCO2 is more than 50 mmHg. The respiratory failure can be acute or chronic in nature related to onset and duration of the failure. Coming to some of the etiologies of type 1 respiratory failure, for that, we should know the alveolar gas equation. Alveolar gas equation, everyone must be aware of. PO2 is the FiO2 minus barometric pressure minus water vapor pressure minus PCO2 by R. The type, this is the PaO2. Then we have to calculate the A gradient, that is from PO2 minus the PaO2 is the A gradient. With type 1 respiratory failure with normal A gradient are the with alveolar hypoventilation or low atmospheric pressure of inspired oxygen. Okay? These are the causes for normal AA gradient with type 1 respiratory failure. Then type 1 respiratory failure can due to increase AA gradient. It can be diffusion defect like emphysema, interstitial lung disease. Can be due to ventilator perfusion mismatch, PQ mismatch, ARDS, patients with ACOPD, congestive cardiac failure, and pulmonary embolism. Or it can be due to right to left sampling to complete atelectasis, pneumonia, pulmonary edema, and AB malformation. So these are the etiologies of type oxygenation failure with normal and increased AA gradient. Then comes the hypercapnic respiratory failure. For going that, we should know what is the PaCO2. PaCO2 is VCO2 minus VT by VD. That is, VT is the tidal ventilation, VD is the dead space ventilation, and VCO2 is the carbon dioxide production. That is, arterial carbon dioxide level is determined by the carbon dioxide production and the ventilation. Ventilation is the tidal ventilation minus dead space ventilation, which is the effective ventilation. Okay. Therefore, elevated partial pressure of carbon dioxide can be resolved from combination of either decreased tidal ventilation like respiratory pump failure, increased dead space ventilation, or increased carbon dioxide production. The etiologies can be decreased central drive, altered neural or neuromuscular transmission, gestural or pleural disorder, dead space ventilation. There is increased BQ ratios like ARDS, bronchiectasis, bronchitis, emphysema, and pulmonary embolism, and muscle abnormalities. These are the various causes of type 2 respiratory failure. This is the pictorial form how there is abnormality in the system that leads to hypercapnic respiratory failure. Obviously, CNS disorder, who is the controller, the main controller is the central nervous system. The disorders like stroke, drugs, infection, all these lead to hypercapnia. Then there can be problem with the wiring. Wiring is the peripheral nervous system disorder. There can be central nervous system with the controller. Then peripheral nervous system, there can be problem in causes like amyotrophic lateral sclerosis, GBS, poliomyelitis, trauma, myasthenia, botulism, and critical illness, neuropathy, and myopathy. There is problem with the nerve muscle disorders. Then there is problem with the bellows. Bellows are the thoracic case. It can be due to trauma, flail chest, obesity, kyphoscoliosis, pleural effusion, pneumothorax, or scar, mainly bone leading to scar formation, critical illness, myopathy, muscle problem. These bellows are not working. Or there can be disorder of the upper airway, obstruction, laryngeal edema, infection, vocal cord paresis, and obstructive sleep apnea also. Or there can be disorder of the lungs that leads to hypercapnia like ARDS, COPD, emboli, infection, fibrosis, and pulmonary rejection. These are the causes of hypercapnic respiratory failure pertaining to various levels of abnormalities. Then decreased muscle strength, obviously, can be GBS, poliomyelitis, disorders of the nerve, Then respiratory muscle atrophy, degenerative neuromuscular transmission can be ventilator dependent, malnutrition, masthenia, myopathy, or critical illness, polyneuropathy, myopathy. All alter diaphragmatic force length relationship like diaphragmatic flattening, dynamic hyperinflation in patients with chronic mechanical ventilator supports. Then how to approach? Most important is to get a detailed history and physical examination. Then what is the detailed history? We have to ask for presence of respiratory symptoms like dyspnea, cough, hemoptysis, sputum production, wheezing, symptoms from other organ system like chest pain, decreased appetite, fever, and weight loss. And already diagnosed with ARB disease, known ARB disease patients, then important to assess the inhaler compliance, technique, recent steroid use, and exposure to environmental triggers. We have to take history for social and addiction history, which is very much important, especially of the tobacco smoking and marijuana smoking. Habits such as having bars and hobbies like driving and flying are also important. Occupational history, considering work-related lung disorders like hypersensitive pneumonitis, pneumoconiosis, silicosis, asbestosis, and detailed occupational history should be taken. Family history of any atopy, genetic disorders like alpha-1 antitrypsin deficiency, cystic fibrosis, or infectious disease like tuberculosis history of family is very much important. Then after detailed history, with a physical examination, general inspection, we have to see the subjective criteria for respiratory failure, that is accessory muscle use, then altered mentation, cachectic, conventional dyspnea, diaphoresis, fever, respiratory distress, at rest or with exertion, obesity, and post-sleep breathing. Then systemic examination for chest or thorax, the most important have to do inspection, palpation, and percussion auscultation in detail. At inspection, we should see the asymmetry of the chestral expansion, bradypnea, kyphoscoliosis, pectus carinatum, pectus excavatum, reduced chestral expansion. Or most importantly, breathing pattern can be chain stroke breathing, Kussmaul breathing pattern, various paradoxical breathing patterns at inspection. Then percussion, dullness or hyporesonance to percussion. Bronchial breath sounds like crackles, decreased breath sounds, loud pulmonal, pleural fiction, bronchi, stridor, tachypnea, vocal fremitus, or vesicular breath sounds, vocal resonance, wheezes, and whispering petroclicky are very much important findings to get there in the proper auscultatory findings. Then other system of examination also have to do. These patients are critically ill, then that should be taken care, like, and various features like asterisk, digital clubbing, peripheral cyanosis, and lower extremities edema, cyanosis, and obviously unilateral swelling. There is chances of DVT and pulmonary embolism can be. Then after history, detailed history and physical examination, then the evaluation. You have to send the laboratory assays like blood panel, CBC, RFT, LFT serum electrolytes, obviously 12-lead ECG, troponin, and infectious workup like blood culture, respiratory sample culture, and respiratory panel pathogen and urinary antigen test whenever it is needed. And monitoring, most important is the arterial blood gas analysis, radiography, long ultrasound, newly coming the chest x-ray, CT scan, and long ultrasound, which is our bedside stethoscope. Then ABG, most important, ABG approach, not going into detail, it is like ABG approach for respiratory acidosis and respiratory alkalosis. They are the respiratory causes that acidosis or alkalosis, then how we have to evaluate for that. The ABG is most important, and we find the cause accordingly that. Then most important is the long ultrasound approach. Bedside tool, very much important. This is the points where you have to focus. Basically, each hemithorax is 4 quadrants, then like 8 quadrants total. Then also the plaques point is set. This is the normal lung finding with A lines and the seesaw sign. Here is the lung and the pleura moving with respiration. Then how with pleural effusion will get, here is the pleural effusion, will get the quad or sinusoid sign. The pneumonia, the tissue sign, it is the massive lobar consolidation of the left lung. It is like, the picture is similar to spleen here, like tissue sign, or it can be thread sign. Thread is the boundary between the consolidated and normal aerated lung. This is the thread signs. Then for interstitial syndrome, we get the long rockets having multiple V lines here. In pneumothorax, most important, here you get the barcode sign in the M mode or stratosphere sign rather than in the normal seesaw sign. And the long point, more specific, that is junction with the normal pleura and the pneumothorax, normal lung and the pneumothorax lung. That lead to this point is more specific, okay, for pneumothorax. Then blue protocol approach for respiratory failure, bedside long ultrasound. The various profiles are there. A profile is normal lung with lung sliding. A-DES is ebolus lung sliding. Then B more like for pneumothorax. B profile is lung sliding with lung rockets, obviously with for fluid overload. B-DES is B profile with ebolus lung sliding due to pneumonia, or C profile indicates enteral lung consolidation, mostly consolidated lung. And AB profile is half A profile one lung and half of B profile of the another. This is the protocol one. This is the lung sliding. If lung sliding is present, then it is A profile is normal lung. If lung sliding present and there is B profile, then pulmonary edema can be the cause of respiratory failure. If it is lung a normal A profile, then you have to think for the sequential venous analysis. A profile lung with thrombosed vein, then pulmonary embolism can be a cause of the respiratory failure. Then if veins are free, then we would later on, I'll tell that. If lung sliding there present with either A, B or C profile, then it can be pneumonia. Pneumonia, there can be A line, B lines also there in pneumonia, also in consolidated pneumonia. Then B-DES profile is the lung sliding is ebolus, then it is pneumonia also. A-DES profile very much important when A lung, that is A profile lung with absence of lung sliding, ebolus lung sliding, that leads to pneumothorax mainly with long point is most specific for pneumonia, for pneumothorax. Then here is the this one like PLAPS point thing. If there is patient is having A profile lung with sequential veins are free, then we see for the PLAPS points for examination. This PLAPS point, if it is positive, then it is pneumonia, or no PLAPS, then can be COPD or asthma as the cause of respiratory failure. This B protocol is very much helpful for evaluating acute respiratory failure in emergency basically. Then management obviously most important is the disease specific management and correction of hypoxemia and hypercapnic acidosis. Various devices like non-invasive HFNC or invasive mechanical ventilation, even ECMO whenever it is feasible. Obviously disease specific management like ACOPD, ARDS, pneumonia, they are having different pathophysiologies and different type of management. So most important is the disease specific management. Okay, pleural effusion to drain the effusion, pneumothorax put the ICD and all that. So most important management is as per the disease severity and disease specific management. As the case you get, your management is as per that. Thank you.
I welcome Dr. Rohit Patnaik sir for the next presentation. His topic is on ventilatory graphics. Rohit Patnaik sir is Associate Professor in Department of Critical Care Medicine, IMS and Some Hospital, Bhubaneswar. Sir, Rohit sir, kindly share your screen and start presentation.
Yeah, just a second, Maulik. Am I audible?
Yes, sir, you're audible, sir.
My screen is visible?
Yes, sir, your screen is visible. Please proceed, sir.
Okay, good evening, everyone. So ventilator graphics is a very big topic, but what I will try to do is only touch on the fundamentals of ventilator graphics. I will not go into a lot of details on the loops and scalars, but I will just try to touch on the various modes as to how they are and what to all to see in the various modes of ventilation. So first and foremost, what is a ventilator? So basically it is an automatic machine which does either a complete or a partial work of breathing of the patient. So this is as simple as that. This is the definition of what is a ventilator. And what are the basic mechanical characteristics of a ventilator? If you see here, first and foremost thing, you need an input power on the ventilator, without which the ventilator won't work. This power has to be converted and get transmitted from electrical energy to being transmitted as mechanical energy to the patient. And third is the ventilator also need to have a control system so that you can control what amount of power you want to give to the patient in terms of tidal volume, pressures, all of that. And last but not the least, what interaction between the ventilator and the patient goes on, you will see it as output or graphics on the ventilator screen. So this is the basic idea about what are the basic characteristics that a ventilator should have. What about the control system, which is the basic model of breathing? If you see here, this is the most important slide of my whole class. So if you see, this is the patient's respiratory system, where it starts from the mouth and reaches up to the airways. And once the airways have gone down, it reaches up to the alveoli. So if you see here, basically the whole respiratory system can be divided into a tube and a balloon sort of complex, where the first part of the tube is actually determines what is the resistance of the airway, and that is basically determined by the large airways, and the second by the small airways and the resistance airways, which you call it. And the second part is basically the balloon part, which is basically determined by the alveoli. Okay, so this is the part which determines your compliance. So this is the basic idea of a respiratory system that you need to have. So when you have resistance, you will usually have a flow with the resistance. And when you have a certain amount of compliance component. Okay, so these are the two basic things that you have to remember when you see for ventilators. So this brings us to the equation of motion. So that is the most important part, again, about understanding all ventilator graphics. And if you see what is the equation of motion, so it is again stems from the same basic model of breathing, where you have a tube part and a balloon part. So if you see the pressure in the whole system, which includes the muscle and the ventilator pressure, is basically determined by the resistance into the flow. Okay, this is the first part, and plus added to the elastance into the volume. Okay, this is the second part. So this whole pressure that you see on a ventilator is basically a sum of these two things. And what are these two things? This is basically resistance into flow plus elastance into volume. So if you just elaborate it further, this elastance is basically 1 by compliance. So it becomes the whole pressure in the system is basically a resistance into flow plus volume by compliance. So if you again try to simplify it even further, if you see here, what are the things that we see on the ventilator? We see pressure, we see volume, we see flow. Okay, so if you see in this equation, we have these three things. That is the pressure, which is muscle pressure, or the ventilator pressure, which is the total pressure. We see for the flow, we see for the volume. So these are the three things that come inside the equation of motion, and this basically determines what comes up on the ventilator graphics. Okay, and remember, all of these things are basically measured relative to their end expiratory value. So that in ventilator graphics, you take the end expiratory values as the reference points, and beyond that, whatever increase or decrease in the pressure, flow, or volume happens is taken as the change. So that is the fundamental concept, that end expiratory values are the ones that you have to take as the baseline. And basically, if you see any system that a patient has in him has some amount of resistance and compliance. So whatever that patient has got such resistance and compliance in his airways and his lungs. So this will determine the amount of pressure that is generated. So basically, in a particular patient at a particular point of time, resistance and compliance are constant. Okay, so that basically is what is important, that once these two are constant, the variations in the flow and the volume will determine the amount of pressure that is generated in the system, and that is reflected as the pressures that we see on the ventilator graphics. So again, the same thing, even more simplified. So if you see, I told you that there is the pressure in the system, which is the muscle and the ventilator pressure combined, is basically a resistance into flow and elastance into the volume. So if you see, the resistance into flow is also called as the resistive load. okay, that the ventilator has to face. And the other part, which is the elastance into volume or volume by compliance, is the elastic load that the ventilator has to face. So based on these two loads that the ventilator faces, it has to a certain amount of pressure is generated in the system based on whether the patient is having complete paralysis where your muscle pressure is absolutely zero, that is the patient does not generate any pressure at all, or if the patient has a certain amount of triggering and a certain amount of support that the patient has in himself, pressure generation, negative pressure, then there will be a certain amount of muscle pressure which contributes. If the patient is completely paralyzed, this becomes zero, and there is only the ventilator pressure, which is determined by the resistive and the elastic load. So basically, the elastic load is the elastance against which the muscles or the ventilator needs to work, and the resistive load is basically the resistance against which the muscles or the ventilator needs to work. So this is basically the basic fundamental that you need to have. So this will also help to understand the ventilator graphics better. So if you see, this is the basic screen on a ventilator. This is the sort of graphics that you see in any ventilator screen. If you see here, there are several things on the screen. This is a prototypical Mackay ventilator screen that I have brought and put in front of you. So if you see here, this is the mode of ventilation which is written, volume control. If you see here on this right side of your screen, there are a lot of things like peak pressure, mean pressure, PEEP, respiratory rate. This is the FiO2, this is the IE ratios, this is the minute ventilation, this is the inspiratory tidal volume, this is the expiratory tidal volume. So all of this are mentioned. So what is more important in the graphics part of things are these things in the center. Okay. If you see here, these things in the center are called as scalars and loops. So what are scalars? Scalars are basically the plotting of one control variable. Control variable is the three things that are controlled. That is pressure, volume, and time and flow. So these three things on the y-axis against time which is the x-axis. So this is continuously going on the screen. So this is the x-axis and this is the y-axis. So y-axis is determined here. This is basically the pressure, time, scalar. So when you speak next time about ventilator graphics, you have to speak in these terms. This is the pressure, time, scalar. This is the volume, time, this is the flow, time, scalar. Okay, and this is the volume, time, scalar. So these are the three scalars that you will see on a ventilator screen. So accordingly, if you see here, if a pressure is there, then it is mentioned in centimeter of water. If it is flow is there, liters per minute. And if it is only volume versus time, then it is mentioned as ml. So based on that as well, you can recognize what sort of scalar it is. Second thing, apart from the scalars, you also have options of bringing in loops. Okay, so what is a loop? Loop is basically the plotting of one control variable against another control variable. I told you three control variables. One is pressure, one is flow, one is volume. So if you plot volume against pressure, you get a loop like this. Okay, so this is volume, this is pressure. Okay, so x-axis centimeter of water, y-axis ml. So if you plot flow against volume, you will get something like this. Okay, so this is x-axis volume and y-axis is flow, liter per minute. X-axis is volume in ml. So this is plotting of one control variable against another control variable. This is called as a loop. So this is called as a volume pressure loop. This is called as a flow volume loop. Okay, so this is how you sort of have to speak when you speak in terms of ventilator graphics. So I will move forward. The other thing that I didn't touch on the screen is basically the four basic things that you set on a ventilator, and you get some ventilator graphics out of it. That is the FiO2, the PEEP, the respiratory rate, and the tidal volume. Okay, so these are the four things that you have to set. So what are the phase variables? If you see, phase variables are basically the things that determine how a particular breath is delivered. Okay, we saw that what are the determinants of a particular breath, that is pressure, volume, and flow. But how that particular breath is delivered is determined by phase variables. If you see here, there is three things that you always have as phase variables. That is the most important. One is the trigger, one is the limit or control. This is also called as the target. Okay, so limit, control, or target. So when you talk of pressure control or volume control, you are talking about the limiting or the targeting variable or the control variable. Okay, so this is what you're talking of when you talk of pressure or volume control. And the third is the cycle. That is what determines whether how you switch from inspiration to expiration. Okay, so cycling can be flow cycling can be time cycling as well. Okay, so based on that, you will have the inspiration to expiration flow. And once you reach expiration, if you keep a certain amount of pressure in expiration, that is called as PEEP. So basically, phase variables are inspiration initiation by a trigger, inspiration control or the limiting variable or the target variable, which during inspiration you are targeting, that is the limit or the control variable. and that can be pressure or flow control, okay, pressure control or flow or volume control, sorry. And cycling can be either flow cycled or time cycled. So this you switch from inspiration to expiration, and once you reach expiration, certain amount of pressure that you keep is called as the peak. Okay, so again, then after PEEP, you go back to again a trigger which starts the initiation again. So these are the basic phase variables that you have to that determine how a breath is delivered. Okay, so I just want to come back to the control variable. If you see here, that control or the limit variable which you set are basically of three, that is pressure, flow, or volume. But if you see, usually flow and volume are coupled. So usually you will have either only pressure control or you will have volume control, which is also called as flow control. Okay, so this is how you sort of classify your ventilators as well, like whether it is ventilator mode, which is either pressure control or flow/volume control. Okay, so only one can be controlled at one particular point of time. So based on that, you have either pressure control or volume control. As I told, some of the smarter modes of ventilation that we have, which we call as pressure regulated volume control or PRVC, are basically nothing but dual modes of control. Okay, where from breath to breath, there is control of both pressure as well as volume. Okay, so this is how dual modes of ventilation. Ventilators are becoming smarter. They are telling that, okay, you can control more than one particular variable, just not pressure control or volume control. From breath to breath, you can control. And the third generation of ventilators and ventilator modes are coming where you can control both the things in the same breath as well, not from breath to breath, but from in the same breath only, you can control that as well. That is the latest generation of things that are coming. Okay. So first we'll start with the volume and flow control. If you see, volume and flow controls, flow waveforms will be constant for both. So usually volume and flow control go hand in hand. For all practical purposes, we will call it as volume control mode of ventilation. So basically volume will remain constant. That is, suppose you give 400 ml, you will get 400 ml. But the pressure will vary based on your respiratory system mechanics. And mechanics means either your resistive load or your either your resistance or your compliance. So based on what the resistance and compliance changes, you will have changes in the pressure, but the volume delivered will be remaining the constant. Okay. So if you see, this is a classic ventilator graphic of a volume control mode of ventilation. So again, as I said, this is the pressure time scalar. This is the flow time scalar that we see on the ventilator, is the volume time scalar. If you see here, there is the flow, which is constant during inspiration. If you see here, this is a square shaped waveform which you see here. Expiration is always passive, so it will always be a decelerating waveform here in the flow waveform, exponential decelerating waveform. But in the inspiration, this is what tells us that this is a constant flow, okay, which you are getting. And if you see here, the tidal volume is also constant. But here, if you see the pressure, since the tidal volume is constant in every breath, the pressure is also seen as constant. But if you see, if there is change in the resistance or compliance, then you will have changes in the pressure. Okay, so this is how you will determine whether it is a volume control, that the flow waveform is constant during inspiration. That is a square shaped waveform. If you see here in the volume controlled waveform, if you delve a little deeper into the pressure, if you delve a little deeper, I'll come to in the next slide. In the pressure time scalar of a volume control mode of ventilation, you have two pressures here. One is the peak pressure here, and one is the plateau pressure here. Okay, so I will come to it later. If you see here, these are the two pressures that you see here. One is the peak pressure and the plateau pressure. Okay, so this is just again same thing. It is a controlled mode of ventilation. Okay, and that is a volume targeted or volume controlled. Okay, as I said, control, limit, and target is the same thing. Okay, so if you see, this is a volume controlled mode of ventilation. So what is the trigger in this volume control mode of ventilation? This is a time triggered mode, because the time is the one with the particular point of time. There is a triggering that is happening. So there is no patient trigger that is happening. It's a completely controlled mode of ventilation where you will have no triggering from the patient. So if you see here, there is no pressure drop in the first part of the pressure time scalar. So this is a time triggered. What about the limit? The limit, as I said, in a volume control mode of ventilation, this is a flow limited. Okay, flow limited mode of ventilation, where there is a particular amount of flow which is coming to the patient. And if you see here, the volume is also if you can call it as volume limited as well. If you see here, the last part is basically the cycling. That is whether it is time cycled. So basically, it is after a particular amount of time, it is getting cycled. It was also a sort of volume cycled, because once it reaches a particular volume, it is getting cycled. Suppose it reaches 400 ml, that is going to cycle into the expiration. So basically, if you see here, there is a preset peak flow in a volume control mode of ventilation. Okay, and if you have changing compliance and resistance, based on that, your pressures will keep changing. Okay, the pressure time scalar will also keep changing. So this is a volume controlled mode of ventilation, where it is a completely controlled mode here, which I have shown. Okay, so there are no triggers from the patient. But compared to that, if you see here, this is an assist controlled mode of ventilation. So what is assist control? This is a volume controlled mode of ventilation, but this is assist control. What assist? Assistance in terms of letting the patient do a trigger. Okay, so patient is able to trigger this particular breath. If you see here, there is a slight drop in the pressure here. So this drop in the pressure is because the patient has triggered the breath. So this basically is the idea behind producing the AC/VC modes that we see in some of the ventilators. So what is AC? AC/VC. VC we know that is the volume control mode of ventilation. But what is AC? AC is basically assist control. So today's all ventilator modes which have pressure or volume control are all assist control modes of ventilation. They will allow the patient to trigger. Okay, so the patient triggers, we can trigger the breath, but the rest of the breath is delivered by the ventilator. Okay, so this is volume control mode of ventilation, but this is allowing for assistance in terms of assist control mode. Okay, so this is the so little bit more on the pressure time scalar on a volume controlled mode of ventilation. If you see, the pressure time scalar is usually looking like this, where you have a increasing amount of acceleration here in the inspiratory part, and once you get to the peak inspiratory pressure, you have a slight drop in the pressure until it reaches a plateau pressure, and then it falls down to the baseline pressure of 0 or the PEEP that you have set. Okay, so if you see here, based on the curvature that you have here and the difference between the P flat and the peak inspiratory pressure, you can say whether that is a resistance problem or a compliance problem. Okay, here if you see, the peak inspiratory pressure is high and the plateau pressure remains the same. So in this case, this is a resistance problem. So if there is an increase in the peak inspiratory pressure and the plateau pressure remains the same, then and the difference between the two increases, then you have a resistance problem. But if both of them increase, that is both the plateau pressure and the peak inspirator, both of them are increasing, and the difference between the two remains the same, then there is a compliance problem. So usually when will you have resistance problem? Resistance problem is usually when you have an airway issue. Okay, as I showed you in the first part, in the equation of motion, in the tube part, if you have a problem that is in the airways, that is either a bronchospasm, or if you have a tube block, that is all related to the initial part where you have the tube based model. In that part, if you have a problem, then you have a high airway resistance. But in the lower part, if you have problems in the alveoli or outside the alveoli in the chest wall, okay, then you have a compliance problem. So here, if you see, if there is increased plateau pressure and there is increased peak inspiratory pressure, but the difference between the two is the same, then a compliance problem, that is a decreased compliance which is there. And you will usually have it in case of pneumothorax, of this tense ascites which is compressing on your diaphragm, there is a compliance problem over there. So this is how, based on your volume control mode of ventilation and looking at the pressure time scalar, you can determine whether it is an airway resistance or an airway compliance problem. Okay, airway resistance or a compliance problem. So if you see, coming to pressure control mode of ventilation, if you see pressure control mode of ventilation, it is slightly different than volume control. As I said, in this, the control variable is the pressure. So if you see, the pressure time scalar is remaining constant here. This is a square shaped waveform here in the pressure time scalar. So this is a square shaped control variable. This is a pressure control. But if you see here, the flow and the volume will vary based on if there is changes in the resistance and compliance of the particular system. That is the patient's resistance and compliance. If it changes, this particular amount of pressure will be delivered. So suppose you have set pressure control above PEEP as 10, there will be delivery of pressure control above PEEP, that is 10. Okay, so that you have, that the patient, the ventilator will deliver, but based on the resistance and compliance, the tidal volume might change. So suppose there is decreased compliance, tidal volume might increase. If there is increased resistance, the tidal volume might decrease. So based on this, the pressure control mode of ventilation is determined that the pressure time scalar will be a square shaped waveform, because the pressure is held constant. So if you see, this is again pressure targeted, means pressure controlled mode of ventilation. It is a completely controlled mode that I have shown here. So if you see here, this is again a time triggered. That is a complete control. There is no assistance allowed in this particular mode. In this pressure completely controlled. Remember, for all practical purposes, such sort of completely controlled modes are not available in today's ventilator. Every ventilator today is an assist controlled mode of ventilation, which it allows for. Whether it is pressure control or volume control, there is assist control available. So if you see here, there is no triggering from the patient here, no negative deflections coming. It is a pressure limited or a pressure controlled. As I said, limit target control is the same thing. So there is a pressure limiting variable, there is a pressure control here to a particular pressure, and it is again a time cycled ventilation. That is, after a particular point of time, it is getting cycled into expiration. So this is how you determine the phase variables of a particular mode of ventilation. Okay, so same thing if you see, this is a pressure controlled mode of ventilation, but here this is assist control. This is the same graphic in the previous slide which I showed, except for the fact that there is allowance of an assist. That is, the patient can trigger the breath. So assistance is basically in terms of allowing for the trigger from the patient. Okay, so this is how you see for the graphics. So just to compare volume versus pressure control, in volume control, this is on the left side, this is pressure control on the right side. Just remember that in volume control mode ventilation, the volume and the flow will remain constant. So just focus on the flow graph, flow time scalar, and see that in the inspiratory part, it is a square shaped waveform, and the pressure will vary based on the resistance and the compliance. If you see the pressure times pressure controlled mode of ventilation, the pressure time scalar is constant in inspiration. That is, there is a square shaped waveform, and the flow and the volume will vary based on the resistance and compliance of the patient. So resistance and compliance is basically the mechanics of the patient's airway and the lungs and chest wall. So based on that, resistance and compliance change, there will be change in the flow and the volume in pressure controlled mode of ventilation. So I hope it is clear till now. So what about dual control? I said that volume control, you will have a particular amount of minute ventilation going, because the particular amount of tidal volume will get delivered. So you have a stable minute ventilation. In pressure control, you will have better synchrony. That is the advantage. Why it is better synchrony? Because the flow can vary. So based on the requirements of the patient, the flow can increase or decrease, and you will have better synchrony with the patient. Ventilator synchrony will be lesser in pressure control. What about dual control? Dual control is what we are having in several of the modes here. One of them is the PRVC mode of ventilation, where based on particular patient's physiology and synchrony, there are several different modes in dual control. It can switch between the pressure control and volume control. So if you have dual control, you can have dual control between the breaths, or you can have dual control in the same breath itself. So that's the latest thing that is there in terms of the modes of ventilation which are available. Okay. So just to clarify a little more of the concept about what is a spontaneous and what is a mandatory breath. So if you see here, I told you in the previous graphic that what is an assist controlled breath. Okay, so assistance is different from spontaneous ventilation. You have to remember that. Why and how it is different? Well, a spontaneous breath is one that the patient, okay, triggers as well as cycles. Okay, so this is one thing you have to, that a spontaneous breath will be triggered as well as cycled by the patient. Okay, but an assisted breath is only triggered by the patient. Okay, remember that one thing. But a mandatory breath is something where you will have either triggering happening or not happening, but the cycling will always be by the ventilator. Okay, that particular thing you have to remember, that a mandatory breath can have assistance, but a spontaneous breath will have assistance with cycling as well by the patient. Okay, so that will be a completely spontaneous breath. So spontaneous breath and mode of ventilation which is spontaneous is a pressure support mode of ventilation. Okay, where the patient will himself determine the triggering as well as the cycling. Okay, so both of that determined. So that is a spontaneous breath. Okay. So if you see, what is an assisted breath? As I said, assisted breath is one where only a particular of the whole mandatory breath is done. That is, the triggering is allowed by the ventilator. Okay. So what about pressure support in inspiration? Okay, as I said, in a spontaneous breath, sometimes in patients in CPAP, you can have pressure support. So you can either have it in CPAP or you can have in SIMV plus pressure support, you can have during inspiration. So if you see, this is pressure support mode of ventilation. So if you see here, there is a particular amount of pressure support level that you set, that is pressure support above PEEP that you set on your ventilator. And if you see, you will get a certain amount of pressure support here. And what happens to the triggering? This is completely patient triggered. If you see here, these are the triggerings which are seen here. And what about the limitation in terms of the control variable? The control variable is the pressure, that is the set pressure support level. And what about cycling? Cycling is again by the patient. So you're saying that this is flow cycling, but this flow is also determined by the patient. So this cycling happens when a particular amount of peak flow is reached. So suppose you said 20% of the peak flow. At 20% of peak flow, there will be cycling into expiration. So that is how the patient determines the cycling as well. So this is a spontaneous mode of ventilation where you will have both the triggering as well as the cycling by the patient. So this is how you determine a spontaneous mode of ventilation, which is a pressure support ventilation. And what about CPAP? This is nothing but only continuous positive airway pressure. There is a continuous amount of pressure which keeps happening. Patients can trigger certain amount of pressure breaths over here, but there will be no pressure support added to this particular CPAP level. This rise in the pressure is basically the patient himself generating a certain amount of inspiratory pressure. That's all it is. Okay. So what about SIMV? SIMV is basically synchronized intermittent mandatory ventilation. So basically it is mandatory ventilation, but if the patient starts developing spontaneous breaths, it will allow for the spontaneous breaths. That is, it will allow for the patient to also take spontaneous breath by triggering as well as cycling. But if the patient doesn't take those spontaneous breaths, it will deliver a certain amount of mandatory ventilation as well. So if you see here, these are all the mandatory breaths. Remember, this is a mandatory breath, but this is again an assisted mandatory breath. That is assist control mode. This is here. Okay, where there is a certain amount of triggering that is allowed. But this is a completely spontaneous breath where there is triggering as well as cycling, which is happening from the patient. So this is a completely spontaneous breath. So both mandatory and spontaneous breaths completely are allowed in an SIMV mode. So this allows you to keep a certain amount of minute ventilation guaranteed and also allow the patient to breathe on his own and allow spontaneous breaths during your mandatory breaths as well. Okay. So what is SIMV plus pressure support? This is basically the same thing, but in the spontaneous breaths, you will have those spontaneous breaths which are getting pressure supported. So if you see here, there is triggering as well as cycling by the patient, but this amount of set pressure support is what gives you extra amount of pressure that is generated in those spontaneous breaths. So you will have pressure supported spontaneous breaths here and the mandatory breaths over here which are there. Okay. So this is SIMV plus pressure support. So this is again the same thing. This is a SIMV mode of ventilation. So remember, this is what I am shown here is synchronized intermittent mandatory ventilation. What is the target variable here? That is the control variable. So in this particular mode, in this particular graphic, this is the volume which is the target variable or the volume control mode. In the particular mandatory breaths which are there, the volume is the one which is the control variable here. Okay, so if you see here, volume is the one which is controllable. Why? Because the flow is constant here, compared to the SIMV mode where it is a pressure controlled mode of ventilation in the mandatory ventilation. So if you see here, this is the set pressure control level. Here, these are all the mandatory breaths in the both sides, and here is the spontaneous breath in between. But the mandatory breaths which are there are having a set pressure control level. So this mandatory breath is also pressure controlled ventilation which is going on in those mandatory breaths. So this is SIMV pressure controlled mode of ventilation, and the previous slide volume control mode of ventilation. Okay, so this is how you differentiate the two graphics. So assist control, as I will not touch again on that. I told you assistance in a mandatory breath, whether it might be volume control or pressure control. Assistance is basically allowing for triggering. That is, a patient can trigger the breath. Okay, but remember, assistance is not equivalent to a spontaneous mode or a spontaneous breath. Okay, a spontaneous breath is one where there will be both triggering as well as cycling by the patient. Okay, here only a triggering is allowed in an assisted mode. That is an assist control mode. You will have only the triggering which is allowed. Okay, so this is how you will determine all your ventilator graphics. As I said, fundamentals remain that you will have to know the equation of motion. You will have to know that the pressure is basically equals to the resistive load plus the elastic load. Resistive load is determined by the resistance into flow, and elastic load is determined by the elastance or the compliance into the volume. Okay, so this is how you will see. And what you will see on a ventilator screen is, again, I will come back to my initial slide which I showed you. That is all the scalars, that is the pressure time scalar, the flow time scalar, and the volume time scalar. This is the scalars, and these are the various loops. This is the volume pressure loop, this is the flow volume loop. Okay, and the other things that you see, this is the mode of ventilation and the various pressures that you will see. I also touched on the peak pressure. I also touched on the plateau pressure. So how will you see plateau pressures? You will press an inspiratory hold. You will see in a volume control mode of ventilation, if you press an inspiratory hold, you will have a plateau pressure which is visible to you. Or if you keep an inspiratory pause, then also you will see a plateau pressure which is continuously visible to you on a volume control mode of ventilation. So just to summarize, ventilator graphics are very useful to the intensivist as it is as echocardiography to the cardiologist. It is as useful as it to the intensivist. You always measure the pressures, flows, and remember, never forget the alarms. I always see residents doing any mode of ventilation, but they never ever go to the alarms and set it when they put a particular mode of ventilation. Always remember to set your alarms according to the particular patient. And even when you pass by the bed, when you see ventilator graphics, you can diagnose a problem by just seeing the ventilator graphics. You don't need to really delve into what is happening into the patient's physiology completely. You can just see the ventilator graphics and diagnose by seeing the ventilator graphics. So graphics are useful to follow patient progress as well and response to treatment. Bronchospasm, patient comes in, high peak pressures, give some therapy, bronchodilators. It might reduce peak pressures, plateau pressures, all of that. You can see whether there is improvement or there is worsening. So graphics will also help you in that particular thing. So thanks a lot for your patient listening. Chandramali, are you there?
I think he has gone somewhere. I think, okay, the next presentation.
Hello, everyone.
Okay. Thank you, Dr. Rohit.
Thank you, sir. Thank you, sir.
Next, I welcome Dr. Samir Samil sir for the final presentation of the day, that is communication in ICU. Over to you, sir.
Yeah, thank you. Hello, am I audible and is my slide visible?
Yes, sir, visible.
Yes, it is visible.
Slide change is also visible?
Yes.
Yes, sir.
Slide change is visible.
Okay, fine. Hello, everyone. So now I'm going to talk about the topic communication and ICU. Mostly I will prepare you for how to write in the theory examinations. Most of you already deal with patient relatives. So most of you know, but to write in exam, you need to cover few points that I'm going to say you about that. And don't go away after this, because after this we have some question and answers about respiratory system. Okay, so I will finish this quickly. This is not that much important. So what you have to write in answers, goal of communication is to convey information. It has to be bidirectional. Okay, so this is an introduction. Okay, factors like tone of voice, word choice, and volume, that depends. Communication requires that we know what we want to say. We are aware of the characteristics of our audience. We choose the most appropriate format for communication. We deliver a clear message and verify that the message has been understood. Okay, so communication has basically three parts. Means three types of communication: three more: patient physician, physician relative, and the physician physician. Okay, so these are the three things that you need to address while writing the answers. So communication with the patient. 1 minute, please. Sorry. Sorry for the interruption. Yeah. So coming to physician-patient relationship, is it audible now?
Yes, sir, audible. You're audible, sir. Please proceed.
Yeah, okay. So physician-patient relationship, so that is to a competent communication between doctor and the patient also. Okay, not only with, communication doesn't mean only with the relatives. We have to communicate with the patient also. Why? Let us see. You have to acknowledge both conscious and unconscious patient. Even unconscious patient, they are able to hear. So when the evok potentials are given, we see that even when the patients are sedated and have a low GCS, the evok potentials show that they are still the auditory stimulus. They still respond to auditory stimulus. Okay. So always as a patient, greet the patient relative, introduce yourself, explain your role. Okay. If the patient is awake, try to know how much he knows about his or her condition. Even so, give information and explanation even to patients who are unresponsive. Okay. So this helps in reducing ICU psychosis or delirium. So then overcoming the barriers. So communication. Okay. Reassure the patient that when the tube is inside, he may not be able to talk, but it is temporary, then he can talk. That gives the patient very surety, so that they can easily, they try to talk whenever they regain consciousness. First of all, they try to talk, so they are like stunned that why are not they able to talk. So explain them, so they respond better, they stay calm on tube. Whenever you try to wean a patient after sedation, they generally are very violent, so if you make them explain that it is okay, it's a matter of time, they respond very well, they stay calm and stay on pressure support mode. So communication can not only be verbal but also non-verbal. Some may hear louder, so this not able to hear a significant factor in delirium because of any middle ear fluid or infection or anything. We have to check also that. Generally we skip ear test. Very rarely we do in our ICUs, but it is good to have a ear checkup. Then non-vocal communication, gesturing, nodding, mouthing words, blinking, lip reading and touch. These also help the patients in recovering faster. Alternative communication, the patients feel better. Alternative communication, pencil and paper, magic slates, felt tip markers, dry erase boards. So this is one example, okay, of communication board. So you can show, I want to see, the patient puts a tick on this. Suppose patient is on ventilator and unable to speak, you can give these. They can tell whatever they want. So it is becomes very easy to communicate with the patient. Now you have to handle the reality of the patient. So those patients you have to deal separately, take care of that. Then you have to always listen to patient's relative. Suppose when there is a communication with a patient, always try to listen more and talk less, interrupt less. There should be minimal interruptions with the patient. Let him speak what he needs all, and from the information you gather from what he speaks, then you ask your questions. Don't interrupt him in between and ask questions. Meet the patient needs, psychological needs become most important. Presence of other people, information, compassion and hope. So positive reinformation and encouragement from family and friends, flexible visiting hours, informed patient tolerate pain more easily, recover from surgery more quickly and cooperate better with therapy. So we have to inform that this is what we are going to do, this will be with you, a tube will be there, a line will be there, you will feel this, you need not worry. So they tolerate it better. Hope and honesty, we have to some balance. Not everybody is ready to hear that disease that they have, or the prognostication part they are not ready to hear. So you should see that whether they're ready to hear this. So hope and honesty are also to be there. So for one example is, without using percentage, how would you communicate a hopeful prognosis to a patient with 75% chance of surviving to ICU discharge and 45% chance of completely regaining physical function at the end of the year? So example is that there is a very good chance we'll be able to move you back if you continue to improve. This is also helpful in a practical exams, because in practical exams the examiner can ask you that how you talk to a patient. So this will be the answer. You will be able to move back to general ward if you continue to improve. So for every 4 patients in a situation, 3 will be good enough to leave the ICU, and you have shown a great deal of improvement. So that makes him feel easy in that 3. So first we need to get you breathing on your own though. That's our goal over the next few days, and we need your help to reach it. There is a fair chance that in a year from now, you may be even back to living a normal life. Nearly half the patients in your situation have completely recovered by then. Okay, so this is a way you tell. This is the answers that examiner expect. Okay. Now there are some difficult patients who are demanding, aggressive, dirty, rude, or violent. You need not be again aggressive on them. So you have to be very compassionate and hear to them and try finding the cause of their demand. Sorry, the cause of their aggression, what the demands are. Okay, so you have to deal with that. Try to address that. That will help. So according to Groves, the difficult patients, they are classified as dependent clingers, entitled demanders, manipulative help rejectors, self-destructive deniers. Okay, so so some means of coping with difficult patients is empathy, non-judgmental listening, patience, directness, setting clear limits for an encounter. Like in the next 15 minutes, we will do this. This is we'll talk this. This is you tell me what is not. So you like your most of the times is not wasted on them. So referral to consultants for mental health services can be done. Humor, it is there in books, but I am not very sure about how everyone will take humor. But you, it is that. So due to patient treatments, they are irrelevant. To involve the patient's family when a patient is very agitated or something. Try involve the family to calm them down. Then relaxation, tell personal experiences, similar experiences to make them feel better. So informed consent, there are 5 principles: disclosure of information, competency, understanding, voluntariness, and decision making. This has to be present in any decision making involving the awake patient. Okay. So consent form, you have to use short, simple words, limit the amount of technical jargon, whatever. Effective communication, these are the headings that you have to cover. Effective communications, so this requires attentiveness, congruence, harmony in verbal, non-verbal aspects of communication. I will tell you later what is congruence. It can be a short note or can be asked. Empathy, facial expression, humor, reassurance, reliability, respect for patient's privacy, simple and non-technical language, soothing vocals, timing and touch. So failure to communicate causes stress in the patient and delayed recovery. So causes of limited communication can be workload, severity of illness, difficulty in lip reading, patient's inability to write, preoccupation with physical and technical aspect of care, personality of the patient also, and lack of appropriate communication skills. So various factors are there: patient factors, ICU factors, workload factors, doctor factors that can cause causes of limited communication. Now coming to communication with family, so you have to provide information to the patients about the patient, what is happening. It has to be clear, accurate, honestly, timely, and in the language they best understand. You cannot just tell your very technical and medical jargons that they are not going to understand. Patient has cholecystitis. Very rarely somebody will know what is a cholecystitis. You have to tell them there is a problem in gallbladder, there is inflammation or infection, whatever, depending on that. Initial meeting on admission, just on admission, you have to explain the current condition. It is better if it is done by the in charge, who is in charge of the patient. Explain the current condition to the patient. Okay, so it is it is the same. If it is the same doctor every time who counsels the patient relatives, it is better, so that the continuity of communication is present. So like answers that you have to give is: what is wrong with my mother, how is she doing, are you going to stick tubes and needles into. These are some questions that they ask. When will he come home, how many days will it take. So you have to then answer this patiently. And okay, and no, be honest, your body language depends. Again, I'll tell that later. Information helps families from reasonable expectations and cope with the distress. They need to hear these answers. So we need to explain the primary diagnosis, and which organs are involved in the disease process. Tell the proper organ's name and not again the medical jargon. Okay, give a balanced but cautious estimate of the patient's chance of survival. So describe the treatments that you will use. Like we are going to hook him up to a machine. It's like we'll put him on a ventilator, a machine that will help him to breathe. That helps in his breathing, like that, or ECMO. Means we are patient his heart is weak or his lungs are weak. These are all needed. Okay. So provide printed materials or links to online information about the procedures and equipment in ICU. Explain the role of members of the ICU and hospital teams. Medical terms to be avoided. Use words that make sense, like clot. For you cannot say acute ischemic stroke. They may or may not get. You have to take clock. Like in Odia, you can tell Dr. Munda, or in Hindi you can say खून का गांठ हो गया है, जो कि उसको हमारे नस को चोक कर दे रहा है, जिस वजह से वहाँ पे खून नहीं जा पा रहा है. Finally, instead of intubation, like these are these words that you have to use. Communication with family as often as possible. So coordinate with your team so that all members are giving the same message, or designate one person to communicate with the family daily. That should not be different information, like surgeon is saying that patient is all good, he will be discharged in 2 days, while the intensivist is saying no, he has fever and shock, now it will take another 5 to 7 days, he is not that good. That should not be there. He is unable, the patient relatives is unable to whom he has to trust. So So that is why there should be a proper communication with the patient relative if present with all of the team together, so that there is so there is no miscommunication or different information passed on to the patient relative from different doctors. So choose one family member to be responsible for disseminating information about the patient to the rest of the family. The doctor communicating should be the same, and the patient relative to whom you are communicating should also be the same every day. So make sure your body language reflects the messages you are giving verbally. Okay, like you cannot be shrug your shoulder and be unhappy and tell that your patient is good and going to get extubated, or you cannot smile and say your patient is not good. Your body language has to be there, and provide this for foreign if provide translators. Ask the listener to restate your message in his or own words. After you communicate something to the patient, it is important to know whether your patient relatives got what you tell or not. Several times I have seen when we counsel the patient relatives, the relatives, you counsel them for 5 to 10 minutes, and then the patient relatives say that I am unable to understand, I will send someone else. So you have to ask the patient relative whether he understood what you want to know, and ask him what did he understand, so that you can know whether you got into him or not. So give information in an organized and logical sequence using signposting and summarizing. Okay. So encourage relatives to maintain a booklet that contains info on the patient's diagnosis, information about treatment plans and goals, question to ask to the medical nursing staff, answers to the previously asked questions. So that helps them in not repeatedly asking you the old questions again. Okay. So there was a study that showed that brochure reduced the proportion of family members with poor communication from 40.9% to 11.5%. Design a toolkit to make family meetings simpler. Like you should already have a plan of what to tell the patient family and what not. Okay, so ensure family meetings takes place every day. Identify convenient blocks of time. Inform them beforehand that this time you will be talking to them, so that they are not stressed out. They know when to uh, respond and when to means when they are going to get the status update about their patients. Okay. So involve family in the patient care. They can detect pain and emotions better. Like they know that when a particular patient, once we are not able to read the body language of the patient because we don't know them earlier. Patient is already intubated. We have not communicated with the patient. They tell the symptoms better family on because they are the last person who have talked to the patient before the patient got intubated. So they better know the what the patient is going through. So they should participate also in daily care, like in morning care. You can allow them to have feed the patient also. Okay, so that reduces the anxiety a lot of the patient. So educating family and encouraging discussion, handling difference of opinions. So as I told, there should be a similar message going through to the every relative and through all the doctors. There should not be any difference. So what you can do is calm yourself, listen attentively so as to better understand the other point of view, know the laws. This is an aggressive patient relatives. Involve people from outside your department in negotiations to reduce the emphasis on us versus them. Now allow the family to consider your point of view and to discuss your recommendations among themselves. Like you give them 2-3 options and tell them these are the outcomes. Now you decide. This is my decision in particular. These are the advantages. These are the drawbacks, and you decide which to do. And you give your own recommendation with that. Okay. So be open-minded. It may be your opinion that needs to change. Okay. So you talk to them. Breaking bad news, preparing families, seriousness of the situation from the beginning. So present a balanced picture. Don't say if the patient is very good also in ICU. Don't say that patient is very good because you never know why the patient is admitted. There are some criteria patient get admitted in the ICU. So anything can go south anytime. So you have to present a balanced picture, highlighting the possibility of both positive and negative results. So explain the possible clinical pathways, even death. Every day you have to tell the chances of death because suddenly after 5 days of saying patient is okay or not okay, okay, not okay, and suddenly on the 6th day you say there are chances of death, they will not be able to accept. So even from the first day of ICU admission, yeah, even negligible chances of death, but you have to tell them about death. That there is 1% chance, 10% chance, 5% chance, sudden death, cardiac arrest, whatever. But death has to be counseled from the day one. Never postpone a meeting of grave prognosis. Like you know the patient is bad, they are giving some, you have to change some treatment modality, and you wait for its response, and that is why you try to postpone. Never do that because you never know whether that is going to act or not act. And again suddenly you have a patient who is dead and you have not yet talked to the patient relative once about the grave prognosis. So never postpone a meeting of grave prognosis. Include family in the end of life care decisions. Ask open-ended questions, like ask what, when. Don't ask why. Why is very rude for them. They are very difficult to answer. Ask why, when, who, where. Okay, don't ask answers like those have those questions. Those have answers like yes or no. That is a close-ended discussion. Like they say yes and the discussion is over. So it should be an open-ended discussion. Like they can give anything. Try collecting information from that. So compassion. Check that your expression I already have told. Private room is better. Break bad news. Acknowledge the reaction and discuss the near future. So this is the flowchart of end of life care. I think Satyajit, Dr. Satyajit would have told about this. Now, organ donation is another aspect that we have to talk to the relatives. This one already I think it would have been told. So summary of family communication: choose a comfortable and private location. Know the patient's name. Verify that you are speaking with the relatives of the right patient. Know the names of other staff members attending the meeting. Introduce everyone. Provide enough chairs. Ask them to turn off their pagers or cellular telephones. Know the topics you plan to discuss. Allow time for questions. Identify the person of the family for further questioning and answering, and who is the will disseminate the information to other family members. End the meeting by summarizing again from starting to again. End the meeting by summarizing decisions made. Now, factors associated with family dissatisfaction and family satisfaction. Okay, I cannot tell again. Just if you want to take a screenshot or whatever you want. Now, communication with co-workers. So we know it is a multidisciplinary team. Integrate the diverse talent towards one goal, that is patient care. So clear assigning of roles is needed, and task also. Coordinated team approach is needed, like treatment, timings, counseling, communication, handovers. The most important thing is a handover. Most important chain of communication. Any loss of information or miscommunication can hamper the patient treatment. Like we are planning a CSF in a fever altered sensorium patient. NCCT has been done. Report has been not yet come. Film has not yet come. But there is a phone from the CT console that the patient has severe cerebral edema. You forget to pass on the information. Your duty gets over and you go home. The new doctor comes and sees fever with altered sensorium, and the CT is done and plans to suppose in the heat of the moment, he just goes for a CSF and there is herniation. So there should be uh, proper communication. So any lack of communication, there are chances of uh, uh, very serious information getting missed. A patient having severe EADs, going for operation was prone 18 hours back, or this antibiotic was escalated this much time back. A patient again doctor again escalates. So communication has to be there. So it is very most important. Checklist can reduce that, but again, that is not foolproof. There is a thing called ISBAR, issue, situation, background, assessment, and recommendation for every patient can help reduce the error. So, situation of the patient, what are the issues, current issues of the patient, what is the background of the patient, assessment that was done during the round, and recommendation because of that, because of those assessments. So, if this is done in every shift on every handover, then there are very less chances of uh, miscommunication, and you can know what the previous doctor thought on which lines. Then you can add your ideas to that, so that helps. So teamwork, as I told, improves efficacy and outcome. You can add your ideas also. Teamwork definitely helps. You miss your previous doctor misses out on something, the next doctor adds up to that, and even he misses out something, then other doctor, the third doctor adds to that. So there is never a miss. Like someone, a patient is having a infection which is sensitive to a seizure patient who is having an infection which is sensitive to fluoroquinolones, and the first doctor added levofloxacin. The second doctor comes and sees that patient is in shock, changes it to imipenem. Then third doctor comes and sees that it was a good escalation, but since the patient is a seizure disorder, starting imipenem was wrong, so he changes it to meropenem, doripenem. So that is what, if one doctor misses something because of the hectic work or what is the teamwork helps in catching the mistake and correcting it. Okay, so retention, so teamwork also helps in reducing errors, retention of quality and staff, handling behavior with nurses. Okay, and so it is very important what the nurses think of a doctor, because that relationship with doctor, it shows that in a study we are directly correlated with their attitude towards the patient. If you are good with the patient, with the sisters and all, they give a proper care to the patient. So that was seen in the study. So team meetings and social gatherings help to increase the bondage, and the that is also a type of communication that increases brotherhood and all. So input has to be taken from all members of the team and not just seniors, and even the junior can provide some new uh, angle or new diagnosis that has not come to anybody in anybody's mind. So always take input from one and then discuss the management plan. So barriers to teamwork are egos, maintenance of strict hierarchy, different values, disagreement over major goals of therapy. Avoid errors. So encourage discussion of safety. It should be confidential, the reporting system, so that somebody is not does not feel embarrassed. Expect employees to share accountability. Encourage teamwork. So develop your communication skills, reflection and learning, awareness, emotional awareness, accurate self-assessment, self-confidence, intuition and empathy that you have to learn gradually by seeing others or taking classes or whatever. Then signals, you should know signaling. Because there are sometimes non verbal communication with the patient, so you have to try to learn the signals also. So for developing communication skills, you need to have empathy, you need to have intuition that what the patient is trying to say or something. Learn signals. Okay. So levels of communication, again, as I told, congruence. So every message has a content and a context. Content, as we know, whatever we want to relate information to the patient, relatives of the patient, and context is the body language, choice of words, intonation, facial expressions. So congruence is that these both should be correct together. They should be matching with each other. That is called congruence. So the congruence helps in building trust in the patient or the patient relatives. Now, communication styles can be either directive, that is doctors oriented, or explorative, patient oriented, patient centered approach. Obviously, patient centered approach is better. So because you get to hear what the patient has to say and all. Again, if your doctor is very assertive and the patient is not so much very literate, then you can also go for a doctor centered, so that the patient has complete trust in you. Okay, so communication skills, attentive listening, asking questions, paraphrasing, reflecting, explaining, checking, understanding, summarizing, concreteness, and structuring. These are the communication skills I will tell. So asking questions can be open-ended or close-ended. Close-ended is yes or no, about why, as I've already told. Paraphrasing, to show understanding, to check you have correctly understood what you have been told. Suppose the patient tells a 15-20 minutes essay, so you have to, that can be random information, so you have to paraphrase it, you have to collect all the information and tell that, so you wanted to say this, so that helps the patient relatives or patient to know that you are listening. So paraphrasing is important. Reflect feelings, draw out the unspoken feelings. Suppose you want to feelings of the person. So if you want to you hear a patient or a patient relative and see that he's trying to say something but hiding that fact, so you try to try to get that information of the patient, so that they don't say directly and you extract it from them. That provides less guilt to them. So that is reflective feelings. Explaining. So give information in small chunks. Important information has to be given first to the patients, because what you hear in the beginning is the most highest retained than what you say in the end. Okay, so first important information has to be provided first. In chunks. Then signposting. That first I will tell your patient what your symptoms, what you have, why you are like that. You tell that first I will tell this, so that they know structured answers. They know what they're going to listen. Now checking understanding, ask the patient or family to repeat what you have told them and ask what they understood. Already I have told. Summarizing. So after, as I told previously, after telling everything, summarize that. So now in the today's discussion, we got to know about this, and this, and this. So that they again agree to what finally it was discussed in the last this much time. Concreteness, that is, you ensure that you have a personal, concrete, and specific information needed for a full understanding. Like it has to be specific answers, concrete answers. Means rather than generalized statements, global statement, it has to be specific answers. Okay, so that is what is concreteness. Then structuring, it keeps you more productive, more keeps the participant more focused. Like telling 1-2 symptoms, then going to pathophysiology, telling the patient discover the tests to be done, then again coming back to symptoms. Instead of that, it has to be more structured approach, so that they understand better. Few terms I think Dr. Satyajit would have told in solar. So face the patient squarely, adopt an open body posture. They are only for questions to be answered during exam. Solar is this. You have to include in your answers while writing the exam. Adopt an open body posture, lean towards the patient family. Use eye contact, don't look at or watch your phone. Maintain a relaxed posture. Value is value statements by family members. Acknowledge their emotions. Listen, understand who patient is as person and how decisions are made in the family. Elicit questions from family members. Then spikes in end of life care. Setting up is for setting up the environment, quiet room, privacy, as I told. perception, patient's family perception regarding progress, what they have understood. It may be totally different from what you have understood. You may think that patient there is no improvement. Patient relatives might think there has been some improvement. You know that FiO2 is 100, but the patient is awake, and but relatives think that yesterday patient was not awake, but today's patient is awake. So they think that patient is better, but actually patient is not better because the patient FiO2 is 100. Or the opposite, you think that there has been improvement, but the patient relatives feel that the patient is still sedated, paralyzed. There is no improvement. So perception is different, that you have to take care of that. So invitation, confirm that the patient is ready to receive the information. So emotional support, then strategy and summary. As I told, the strategy and summarize what we have talked. Okay. So thank you. So this is all about communication. I know you all are very much bored by this. Even I was very bored by while preparing these slides. Am I audible to everyone?
Yes, sir, you're audible.
So now coming to the question discussion. Everybody is ready? You may switch off your microphones, or you may write in the box whatever you want.
Sir, Samir sir, before going into the questions, I'm having a small query from myself. So, about the concreteness in the communication. So we should be specific regarding communication. That means that when the term concreteness has come in your slide, so you mentioned that there is a personal or specific communication. Means the specific communication that we should communicate to the
from our side. Yeah. They will not be concrete. They will tell you lots of stories. You have to listen all of them.
Okay.
Your answer should be concrete.
Concrete. Okay. Sir.
Okay. Like you cannot tell that we will think of doing surgery, may or may not do tomorrow, day after tomorrow. No, it has to be a surgery needed, not needed. It has to be specific. Tomorrow or day after tomorrow, specific. In 2-3 days time, we will do a test in 2-3 days. If this happens, that happens. Not like that. It has to be a concrete answer. Okay, just as an example, there are many things. Your answer has to be concrete, structured and concrete, to the point. You cannot tell 10-15 lines about a specific thing and confuse them. They don't want to get confused. They want clear-cut answers. Okay.
Okay, sir. Thank you.
So, are we ready for the question answer session?
Yes, sir. Please proceed.
Yeah. So, a 32-year-old woman sustained a closed fracture of the right distal radius and ulna yesterday. So, she had this got this fracture reduced under IV regional analgesia with Prilocan 20 minutes ago. You are asked to review her with a view to admission to ICU because she was stanosed centrally and peripherally and felt mildly breathless. On high flow oxygen also the oximeter reads only 88%. This is the ABG, pH 7.4, PCO2 32, PO2 is 326, bicarb is 22. So what is the likely diagnosis?
Prilocan related methemoglobinemia.
Very good answer. It must be Anjali.
Yes, sir.
Right. Yeah, excellent answer. So the best thing about methemoglobinemia is that easy to diagnose. The saturation will always stay at 85 to 88%. Even if your PO2s are high, give any amount of oxygen. In methemoglobinemia, your saturation will always show 85 to 88. Okay. So how do you confirm?
Methemoglobin level on ABG.
Okay. How much is the normal?
(1 to 2%).
Anyone else?
Dr. Ari is messaging, sir. Methylene blue is the treatment, and you have not mentioned about levels.
Less than 5% normal, sir.
Yeah, somebody is asking less than 5%.
Yeah, up to 5 with already generally.
Yeah.
Okay, so how will you manage this patient?
Methylene blue.
Again, first not methylene blue. how will you manage means it has to be ABCD
ABC.
anyways. So what, because the answer is here airway, breathing, circulation. So here we have to take care of the oxygenation. Why? Because there is methemoglobinemia, whatever available hemoglobin we have, it has to be saturated with oxygen. So that is why oxygenation is the important answer first, then methane. Okay. So what is the methane to anyone? Methylene I had told in one class, not in methemoglobinemia, but in another treatment, post cardiac surgery.
Somebody answered vasoplegic syndrome, sir.
What is?
Vasoplegic syndrome.
In that we used. What was the dose there? That dose was based on this only, because you don't give any random dose to the patient. Doses are always given based on some known dose and treatment. So based on this, what is the treatment that time?
1 to 1.5 mg per kg.
Yeah, very
1 to 2 mg per kg.
Okay, 1 to 2, 1 to 1 to 2 mg per kg IV. And what history would you take in this patient? What specific history you have to take in this patient? The last question.
Sir, somebody answered a G6PD deficiency.
Excellent answer. Who has given that? Dr. R or who?
It's a Dr. R.
Very good. Excellent answer. So you have to always take the G6PD
deficiency
history of this patient, because there are chances of severe hemolysis if you give methylene blue to this patient. Okay, so if there is G6PD deficiency, you may have to avoid methylene blue. So next question. 40-year-old man, hepatitis C, dyspnea, jaundice, spider navy, ascites, X-ray spirometry normal, standing saturation 88, supine saturation 97. Why?
Hepatopulmonary syndrome.
Excellent answer. Very good. So pathophysiology, anyone? What causes this?
Pulmonary vasodilation. Intrapulmonary vasodilation.
Yes, why? So what happens in vasodilation? we do vasodilation in pulmonary hypertension, that improves oxygenation. So here what happens because of vasodilation, that there is a fall in saturation on standing. So why on standing? Anyone?
Increase in shunting, sir.
Why on standing?
Because the lung has 3 zones. There's even in zone 1, it is vessels are open.
So blood flow very high. In which zone?
There's zone 1 is
zone, yeah. Zone 1 is?
Zone 3 rich in blood. Zone 1 ventilation is more, perfusion is less.
In zone 1. So zone 1 is where? In the apex?
Apex.
Yeah, yes, sir.
Zone 3?
In the base, where the perfusion is more.
Perfusion is more. Okay. So when a patient is standing, your perfusion is more at the bases. So that is because of the dilation. So more there is leakage and there is worsening of gas section at the bases. But when the patient is standing, so that is why saturation is low while standing. But in supine, what happens? There is no dependent, less dependence on the zone 1, 2, 3. They get equally distributed the pulmonary blood flow. So that is why on supine the saturation is normal. Okay. So which further investigation to confirm? what can you do? What can you do to
ABG, alveolar difference.
AB?
ABG to look for alveolar difference.
In two different positions?
Yes,
No,
sir.
I'm like asking, yeah, that will be there, but that in several.
Contrast echo.
Yes, how is that done? Very good. How is that done? What is the contrast used?
Agitated saline.
Very good. Agitated saline. Why?
To see the shunt.
Yes.
Somebody messaged me air bubbles, sir.
We have to see a right to left shunt. Yes, air bubbles. But that can be seen on a ASD also.
No, sir.
It depends upon after how many cardiac cycles the air bubbles are appearing
Exactly.
in the.
Very good. So in a cardiac shunt, there will be, so you have to do echocardiography, do agitated saline injection. If there is immediate visualization of bubbles in the left side, that is a intracardiac shunt. If there is a delayed, that means it is a what? Pulmonary shunt. Okay. Yeah. Very good. Excellent. Excellent. Very good. So is liver transplant likely to help?
Yes, sir.
Liver transplant is a definitive treatment.
Yeah, definitely. So liver transplant and reverse this. Okay. Where is transplant contraindicated? Anybody? How do I ask this question? Means which pulmonary involvement in liver patients you cannot do liver transplant. There is pulmonary involvement. Okay, that is breathlessness. There is pulmonary involvement in a patient of CLD, DCLD, and you cannot do liver transplant. Is contraindicated in which patient? Anyone? See, here there is vasodilation because of the pulmonary shunt. So that is why transplant will be helpful. But when there is vasodilation, not, there is opposite of that. That is vasoconstriction. So that is pulmonary hypertension. That is a contraindication. Okay. If instead of pulmonary vasodilation, if there is pulmonary hypertension, then that is a contraindication for going for a liver transplant. That will not improve on your liver transplant. Okay. Hypertension will not improve. Now just tell me one thing. So what is this process, this thing called hypoxia and standing, but normal and supine?
Orthodeoxy.
Yes.
Orthodeoxy, sir.
Yeah, orthodeoxia. Very good. Very good. And breathlessness in erect position. Orthopnea is sleeping, means breathlessness during sleeping. Everybody knows. So breathlessness while standing is
Platypnea.
Platypnea. Very good. Very good. So next question. The patient has fecal peritonitis for the last 2 weeks. That is, the patient was not was given feeding. Patient was put on TPN because of your generalized ileus was present. Then mild generalized weakness. Pressure support is only 12. FI2 is 0.2. Afebrile. CPAP is 5. These are the pH. CO2 38, PO2 92. Bicarb is normal. Everything is normal, but is unable to wean. Why?
Hypophosphatemia resulting in respiratory paralysis.
What?
Hypophosphatemia resulting in respiratory.
Hypophosphatemia. Where is your hypophosphatemia?
Patient is on TPN.
Patient is improving, but still patient on TPN. There may be hyperalimentation related weaning failure.
Okay. Okay. Anything else?
Other possibilities, refeeding syndrome.
Okay, but this question has. Do you think this question is asking about refeeding syndrome without giving any phosphate levels, magnesium levels? See the graph and tell me.
Stress index is actually having upward concavity. So
What does that indicate?
flow starvation is actually there. So
Why there is flow starvation? That we have to know, no? Why it is there? Now tell me what is the rate of the patient, respiratory rate of this patient.
Respiratory rate. 30.
Very good, 30. So there are 5 breaths in 10 seconds. So RR is 30. What is the PCO2?
PCO2 is 30.
Yeah, it is also. How much?
PCO2 is 38.
38. Do you think a RR of 30 will have a PCO2 of 38?
CO2 retention is
Due to?
Retention.
Retention, why? Why do you think there is retention? Your graphs are pretty much smooth. PEEP is also 5.
Pressure support may not be sufficient enough to generate the tidal volume.
Generate tidal volume. What is the volume generated according to graph? How much?
It's more than 500 is there.
So the minute ventilation is now around 21 liters, suppose 730. 21 liter. At minute ventilation of 21, your ETCO2 is still 38. Means your PCO2 could be around 43, 44. So there is increased production somewhere. What could be the cause of increased production?
Calories, high carbohydrates from TPN.
High?
Carbs.
Yeah, high carbs. So TPN we are generally giving maybe more than higher doses, required doses. Okay. So this is a overfeeding syndrome. Okay. So more carbon dioxide production, that is why the patient is hyperventilating and we are unable to wean the patient because of the tachypnea. So this is overfeeding. Okay.
Okay. Okay, sir.
Got it? Understood now why?
Yes, sir.
Okay. Okay. So 36-year-old man, woman, 48 hours of cough and SOB, worsening SOB. X-ray shows alveolar infiltrates. Spirometry, this is your FVC. Okay. FEV1 by FVC. This is the diffusion capacity. So, what is the cause of SOB?
Restrictive lung disease.
Tell. Your FVC is normal or low?
Sir, FVC is low, but FEV1 by FVC
So,
is normal, which denotes
yeah. So what
probably
is that?
Slightly
Obstructive or restrictive?
restrictive type arise.
Restrictive.
Because FEV1
So,
by FVC is
yeah, FEV1 by FEV is in the little higher side, no, normal side. So it has to be restrictive, okay? But the thing
Sir,
is,
answer is restrictive, sir.
Yes.
What is the answer, sir?
I am not yet come to the answer. There is a reason.
Okay.
Another two data are given.
Diffusion.
Diffusion capacity of carbon monoxide. Very good. Now the diffusion capacity of carbon monoxide is higher than the predicted. Okay. So why? See, it is higher than the predicted, but in normal range. But when adjusted according to alveolar volume from the FE1 F by C, it is showing grossly enlarged, increased. Okay. So what does that say? Any idea? Or should I tell the answer?
Asthma or I don't know.
No. We have a restrictive disease with us, no?
Good. Yes, okay.
It cannot be asthma. If it would have been an obstructive pattern, then we could have gone for asthma.
Don't know.
Okay. So there is some blood in the alveoli. Okay. That is causing the restrictive pattern. But because there is blood in the alveoli, that is causing your higher diffusion of carbon monoxide. So blood in alveoli means?
Pulmonary edema? No.
More of
Alveolar hemorrhage.
alveolar hemorrhage, yeah. Fluid will not cause your increase in DLCO, okay? It has to be blood present, frank blood. Okay? Got it?
Okay, sir.
Understood, everyone? Why the DLCO is higher in restrictive with restrictive?
Yes, sir.
So, 60-year-old man, 5 years increasing SOB, your FBC, FEV1 by FBC, plethysmography shows vital capacity, total lung capacity, residual volume, FRC, diffusion capacity. This one you tell.
All the volumes are on the lower side. Restrictive. It also looks like restrictive.
Yeah. So this is a totally restrictive. You see here how DLCO is on the lower side. So this is a total restrictive. Okay. Everything just satisfies the restrictive criteria. 2-3 examples of restrictive lung disease.
Fibrosis.
Pulmonary fibrosis. Tell the full answer. Idiopathic pulmonary fibrosis. Okay. And only fibrosis. One. Any other restrictive?
Any interstitial lung diseases?
Okay.
Or granulomatous diseases like sarcoids.
Okay. Any other?
Any wall deformities, kyphosis.
Kyphoscoliosis. Occupational?
Occupational.
Silicosis.
Asbestos.
Yes, very good. Yeah, silicosis, asbestosis, coal worker pneumoconiosis. Okay. Very good. So 60-year-old woman presents with 4 years of increases SOB. FEV1 is grossly reduced. What is this?
Obstructive lung disease. FEV1 by FVC is low.
Yeah, very good. And obstructive lung disease, the DLCO is reduced. What is that?
Emphysema.
FRC is very high. What is that? Emphysema. Very good. Very good. Okay. So this is the emphysema. Very good. Excellent answer. So 32-year-old man, shortness of breath on exercise was 2 years. Your FBC, FE1, FBC, these are the values. Plethysmograph, vital capacity, reduced lung capacity, normal, residual volume, high, functional residual capacity, normal, higher than the predicated but within normal range. Helium dilution shows vital capacity, reduced total lung capacity, reduced residual volume, normal. So what is this? What is this?
So exercise induced, but
Exercise induced?
Is normal, sir. The FVC is low, but FEV1 by FVC is normal.
Yes. So, is it restrictive?
This pattern is towards restrictive.
It can be towards restrictive. Now, what is your this one?
But lung volumes are almost
yeah,
total.
Yes, so can be the cause. Helium dilution plethysmograph show very high lung volumes, but with restrictive. So, what can be the diagnosis? So, this is telling gas trapping. Where do the gas get trapped?
Cavities.
Very good. Little bit modification of that cavity.
Communicating cavities.
Okay. Any other answer? Those are not actually cavities. We avoid NIV in them. Positive pressure ventilation in them. Yes. Tell. Bullous emphysema. The cavity that you're saying, communicating cavity, can be a pneumothorax also. Pneumothorax can also show this kind of pictures. What is going against pneumothorax? It is a bullous emphysema is the answer. Okay. So why is not pneumothorax? What goes against pneumothorax?
Lung volumes.
Yes.
Have got reduced. So,
Lung
volume should have got.
Lung volume should have got reduced, but there is air leak into the pleural space. No, that will get counted in the lung volume, so it will show higher. That is what pneumothorax says. No, connecting to the pleural space, so higher lung volumes. Why not pneumo? What goes against pneumo? Leave the readings. See the question again.
Not acute.
That is over. Time duration?
2 years he's having.
2 years. So that is what goes against your pneumothorax. Okay. So now 45-year-old woman presents with acute respiratory distress, obtunded, intubated, ventilated. So after intubation, this is waveform. Tidal volume 500, rate is 13, FiO2 0.4, peak inspiratory flow rate of 100 liter per minute. So what is the cause of a respiratory failure?
Obstructive lung disease.
Yes, very good. Obstructive lung disease.
And pressure time scalar, we could say auto PF.
Auto PF, very good. So What is the treatment? The
Reduce the
patient
rate.
BP is 60 by 40.
Bronchodilators.
Patient BP is 60 by 40.
Disconnect the ventilator.
Auto beep. There is auto beep. Disconnect the ventilator
Very
connector.
good, very good. First thing you have to do is disconnect the ventilator when there is. Have you ever seen? Have you ever seen disconnect the ventilator and rise of BP? BP goes from 60 by 40 to 132 by 140 by 80. The moment you disconnect the ventilator, it is very, very effective if there is really a dynamic hyperinflation. Okay, immediate increase in BP. Okay, so first you disconnect the ventilator. Then what are other methods to reduce your dynamic hyperinflammation or autopip? One is bronchodilation. Others?
Decrease the rate further.
Decrease the rate further. Very good. Excellent answer. Then other?
Prolong the expiratory time.
Long. Very good. Excellent. Long expiratory time.
Reduce tidal volumes.
Reduce tidal volume. Very good. Excellent answers. Very good. Very good. So these are the formats. One by one you have to tell. Excellent answer. So 36-year-old woman unconscious from swimming pool, 50 kg in weight, intubated a ventilator. So after ventilator, this tidal volume 500, rate is 15, FiO2 0.8, peak inspiratory flow rate 6 liters per minute, PO2 is 55. So what is there? Easy. What is the diagnosis? As easy as it gets.
Hypoxemia is there.
What is that? ARDS. Very good. Full answer. ARDS. ARDS due to?
Partial drowning.
Drowning. Very good. Simple, very simple answer. Then what modifications will you make to this ventilator settings?
Reduce the tidal volume.
Very good. Reduce the tidal volume to?
6 ml
6 to 8 ml per kg.
6 to 8 ml per kg. Excellent. Okay. So then what can you do? Oxygenation doesn't improve.
PEEP, titrating the PEEP, finding the optimal PEEP.
Very good. What is the
Increasing
PEEP?
the inspiratory.
You have the PEEP here in this one. What is the PEEP here?
PEEP is 5.
Around 5.
Here PEEP is 5.
Yeah, PEEP is around 5. So you have to increase the PEEP gradually. Okay. So ARDS you have told no how to titrate PEEP. You have been taught. Previous classes ARDS you have been taught no how to titrate PEEP.
Yes.
Okay. So 45-year-old man, increasing SOB, hypoxemic failure, infiltrates on chest X-ray, 80 kg. So tidal volume 500 ml, RR 15, FiO2 0.5, peak inspiratory flow rate is 60 liters per minute, PO2 is 85. Tell about the waveforms.
Airway obstruction. The difference between PEEP and PEEPlet is quite high. It looks high.
Yes.
Obstructive lung disease.
Difference in the peak and the plateau pressures. Maybe tube bite secretions. Sorry for missing out. Say again, please. What do you suspect?
Airway obstruction. Difference between PEEPlet and PEEP is higher.
Why? Yes, definitely PEEP is higher, and difference between PEEP and PEEPlet is higher, and only obstruction. Any other thing?
Inadequate flow.
What one? Limited flow.
The flow is inadequate, sir.
Flow is inadequate. Why? Can you tell me what is this?
Inspiratory pause.
Very good. Inspiratory pause. Okay. So now, okay, I'm going to give a hint. Can you calculate compliance from this graph?
So we need tidal volume is 500. We need P plat minus P.
Yes.
Difference.
What is the P plat?
Sir, somewhere around 40, sir.
40. Okay. What is the P?
Minus P is 535. 500 by 35.
How much that comes around? 500 by 35. Around 12 or 15, something like that.
14,
right?
14 something. Yes, sir.
14. Okay. So what does that say about the lungs? Low compliance means?
Very poor compliant, low compliant lung.
So is it only obstructive lung disease?
No.
Is it only obstructive lung disease?
No, sir. Some ARDS component is also the problem.
Very good. Very good answer. So some days ago, so sudden hypotension. What happened here? CO2 gradually comes down. PVP and there is sudden shock hypotension.
Embolus.
Very good. Excellent answer. Excellent answer. How to prevent?
Sir, how to prevent?
Yeah. How to prevent embolus generally in any patient having a CVC, central line, whatever?
Position of patient.
Very good position. Head up position has to be there. Okay. And how to treat this? That embolism, not this, the previous question. Embolism. How to treat this?
We considering venous air embolism, sir.
Yes.
If it is due to central line related air embolism, then aspirate the CVP line.
Yes.
Positioning. Positioning.
Position, yes. What position? How do you aspirate?
Sir,
What
head and low.
Yes.
And put him on the lateral side, sir.
Which lateral?
To the side on which the center, on the side of central line.
No. If the central line is on the left side, you will keep right up or left up?
Left up, sir.
Left lateral position.
Left up.
lateral position.
Always has to be left lateral. Why?
Because the air will come up.
Where? In the right atrium? No, it is in the venous side. Right? Understood?
Sir, no, sir. Which side we have to tell, sir, actually?
See, any side it is your patient is a line. It is in the IV, in the what it is called?
SVC RA junction.
With the SVC RA junction, your RA has to be kept up.
Okay, right up should be done. Okay, sir.
Understood. Wherever your line be, on the left side or right side. Okay. Now, if the patient, your line is on the left side, and you put the patient what left up or right lateral, your right at chamber is now below the left atrium, so the air bubble goes into the septum. Understood?
Yes, sir.
Understood or not?
Yes, sir.
Okay, it has always to be right up. So the air bubble comes to the junction of the superior vena cava and the right atrium. Okay.
Okay.
Okay. So 16-year-old woman, diazepam or whatever overdose, patient was intubated with grade 1 laryngoscopy, SpO2 100, VTSO2 is this. What is the cause?
Esophageal intubation.
Finish. Very good. Esophageal intubation. Very good. 3 months of increased SOB, X-ray completely normal, means clear, not normal, clear. Height 195, weight 100. So what is this?
Restrictive pattern, sir.
What?
A restrictive pattern.
Why restrictive?
FVC and FE1 are on the lower side, but FE1 by FEC is not on the normal or on the higher side, sir.
Okay. But there is in the diagram, there is something present that shows. See the loop. What are the 3 diagrams?
All the volumes are on the lower side.
Yes, all the volumes are definitely on the lower side.
Yeah. Above one is the expression, below one is the inspiration, sir.
Yes. Now there is one extra, what is called, what do I call it? Extra data here. Why is it there? FEF and FIF.
Post bronchodilatory effect.
Yes.
Post bronchodilatory effect.
Post bronchodilatory effect. No.
Medium airways.
Yes.
Some info about medium airways, sir.
No.
Sir, someone answered tracheomalacia.
Tracheomalacia. Okay. Why there is tracheomalacia? What does this say actually? Why did you tell why this tracheomalacia? What from what data?
Dr. Laukia, can you answer? You answer is tracheomalacia. Can you give explanation for that?
That is a good nearby answer. The cause of tracheomalacia?
Obesity, maybe hypothyroid.
Yes. What is that answer?
Sir, obesity, maybe some thyroid swelling.
So this is actually a fixed airway obstruction. Okay. Why? Because you see FIF is 1.58. FEF is 2.67. Okay. But your FEF by FIF is should be less than 1, but it is 2.17. So what does it tell? Your FEF is the numerator, FIF is the denominator. Okay. Although both are reduced, your FIF, both inspiratory and expiratory are reduced. But your inspiratory is reduced more than your expiratory. Understood? Didn't understand?
Ji, sir.
Huh? See, both understood, no? FEF and FIF both are reduced, but FEF by FIF, they are not equally reduced. FIF, the inspiratory flow is more reduced than the expiratory. So that tells a fixed large airway obstruction. Okay. So here it is a thyroid mass.
Okay. Extrathoracic obstruction, let's say.
Extrathoracic. Excellent. Very good. There is an extrathoracic obstruction. Very good. So 36-year-old man has gas gangrene, open ankle fracture. So SIMB, F5 to 40, peak 5, tidal volume 500, RR 16, peak pressure is 38. Your ABG shows pH 7.33, PCO2 45, bicap normal, PO2 76, SPO2 of 91. So he was treated with hyperbaric oxygen and 2-point atmosphere hyperbaric oxygen was given. He rapidly becomes difficult to ventilate. 100% FiO2 is now needed. On that, SPO2 is only 71. Pressures have gone high up to 60 from 38. And said tidal volume we are not being able to deliver. pH has become 7.12. That is hypercapnia. PCO2 is 92. So why? What is the cause?
Pneumothorax.
Pneumo.
Excellent. Very good answer. That is pneumothorax. Why?
Because of hyperbaric oxygen.
Hyperbaric oxygen related.
Very good. Any other causes? Suppose the patient was not on hyperbaric, but these findings happened. Again, what can be the causes? Suppose patient has not yet gone into hyperbaric oxygen and this thing happens. Patient is going to hyperbaric oxygen. On the way, this happened. What can be the cause?
Embolism.
Fat embol.
Huh?
Fat embolism.
Fat embolism. The PCO2 will increase or decrease in acute embolism?
Should decrease initially.
Initially it should decrease, then it will increase. Initially there will be a decrease in PCO2, but I told no immediate this happened. Very common, regularly happens. On the way is the clue.
Not getting ventilated.
Why?
Any disconnection or ventilator?
Disconnection, could be kinking. Transport, no? While you transport, anything can happen. Kinking of tube can happen. Tube may be displaced, dislodged in the trachea, has come out into the esophagus. Okay. Anything can happen. Okay. So those are the other answers. So how will you manage? So patient is in hyperbaric oxygen therapy and this happened. How will you manage?
Needle decompression followed by ICD.
Okay. Where? Where? Suppose you use hyperbaric oxygen, you don't have. Yes.
Fifth space, sir, intercostal space.
That is ICD. Suppose their ICD is not present. You are in the hyperbaric chamber, no? There the ICD is not present. You have to go for a needle. Okay. So where will you do that?
Second intercostal space, mid-clavicular line.
New guidelines said that it is in the fifth intercostal space only.
Even according to new guidelines also it is fifth ICS. Okay. That is what I wanted to know. Okay. Okay. Even needle decompression has to be done in the fifth ICS, not the second ICS. Earlier we used to do in second ICS, but now they have changed the guidelines to do it in the fifth ICS. Significant pneumothorax, only that needs to be drained, and you can give a underwater seal by putting a needle, IV set into the needle, keep it in the saline bottle, underwater seal, till your ICD comes to your rescue. Okay, very good. Everybody got it?
Yes, sir.
So 27-year-old man, okay, this is the last question, okay, for today. So 27-year-old man, abdominal and chest trauma 2 days ago, right-sided pneumothorax, ongoing pleural layer leak. So liver laceration is being managed conservatively. SIMB, tidal volume 800, rate 16, FI to 0.5, peak is 5. Nasogastric feeding 3000 ml per day of enteral nutrition, 1 kilocalorie per ml. Indirect calorimetry, VO2, VCO2, respiratory quotient, TEE. So what should be done?
Reduce the volume, sir.
Reduce the?
Recommended is 2000 kilocalories, so 2000 ml should be given.
Yeah, so the total energy expenditure is 2000, so you have to come down on the
Volume of the
because we are giving 3000 kilocalories, 3000 kilocalories. When can this be allowed?
Burns patient.
Okay. Yeah, severe malnutrition and all, when you want to increase all this, bigger the calorimetry readings are mostly normal. So this is your TE is around 12,000, but we are giving 3,000. So this is overfeeding. Okay. Only when there is severe malnutrition, burn patient, you may try giving higher feedings. Okay. So all right, this much for today. Thank you. Any doubts or questions? You can share in the group. And if you want again any recommendations of any topic which have not been covered, you want us to cover, again you can write in the group so that we will cover them. Or any methods you want us to change, that also you can write in the group. Okay, so good night for today. Thank you everyone.
Thank you, sir.
Thank you, sir.